Good morning, ladies and gentlemen, and welcome to SimUPWars 2023. I would like to hand over to our Dean, who will handle the official welcoming, Professor Tiaan de Jager.
Thank you, Runel. Dear distinguished guests, that's you with a VIP label. Faculty, partners, participants, and future trailblazers in health sciences. Welcome to this electrifying spectacle, SimUPWars 2023. Today, we're not only pushing boundaries, we're shattering them. We get ready to witness a clash of clinical titans, where knowledge, skills, and teamwork collide in an adrenaline-fueled competition. SimUPWars isn't just an event or competition. It's an adventurous journey into the heart of healthcare simulation. Building on the success of CPR Day 2019 and last year's SimUPWars, this edition promises an even more immersive, educational, and to be heart-racing experience. Hold onto your seats, because joining us today are, amongst others, the incredible heroes of rocket helicopter emergency medical services, masters of the skies and saviors on the ground. They've brought with them cutting-edge material and simulating technology, adding to the authentic touch that will elevate your learning experience to unparalleled heights. Stay tuned for an inspiring showdown between Rocket HEMS and our own UP Department of Emergency Medicine team. Tuks of Nuks. It's a face-off of epic proportions, where skills will be put to the ultimate test in a live simulation that will be life-changing and be a great experience. A huge shout-out to our 10 teams of undergraduate students, handpicked for their diverse backgrounds and united by a shared passion for healthcare. They've been guided by Dr. Wayne Grobler, whose mentorship has been instrumental in honing their abilities. Today, we're not just competing. We're forging lifelong bonds, sharing invaluable knowledge, and preparing for the challenges that's ahead in this world of healthcare. This event is a testament to our unwavering commitment to excellence in healthcare education and a celebration of collaboration and innovation. Kudos to Professor Runel Hasselman for propelling SimUPWars to greater heights. Watch this space, because she's got even more groundbreaking plans in store for Health Sciences Center for Simulation and Innovation. Trust me, it's going to be a game changer. I also need to acknowledge the support of our friend, a former dean and an advisor, Professor Dion du Plessis. So let's seize this opportunity to learn, grow, and showcase the extraordinary talent within the faculty and institution. May the best team triumph. But remember, today we are all champions in the pursuit of healthcare excellence. Well done, #LifeChanges. Ladies and gentlemen, sponsors and partners, thank you for being part of SimUPWars 2023. Wishing you all a day of brimming with learning, heart-pound excitement, and in the spirit of camaraderie. Thank you.
Thank you very much, Prof. de Jager. So SimUPWars was born during the period of COVID. And I think if I should say the words, wat dink julle van as ons die volgende doen, then the Skills Lab staff would just bow their heads, because I come up with all these ideas and they put it to life. So without Liesel, Wanda, Yvonne and Felicia, none of this would have been possible. And I really want to take the opportunity to say that, yes, we have the best Skills Lab at UP. And we really look forward to becoming a centre to show you what we're going to do even more. Then I also want to say a huge welcome to colleagues from Africa joining us as the Africa Simulation Network, a platform that was recently launched at the University of Cape Town. So Joe Park Ross and Marvin Jansen, if you are online, and all the colleagues from all over Africa, you're most welcome, and we look forward to spending the day with you. In terms of housekeeping rules, the bathrooms, as you exit the venue, you only will be able to use this door when you enter and exit the venue, because that's a prep area for the advanced teams, so please don't peek in there. The bathrooms are to my left-hand side as you exit the venue, and then we'll announce the program as we move along. I'm sure you all have an electronic copy available as well. Then, in terms of debriefing, I just want to state that if there's anything that happens today in the simulation that causes a disturbance or upsets you, please feel free to make contact with any of the Skills Lab staff so that we can support you and I lost all my English words. Verwijs. Refer you to the student support services that we have on campus. Okay, then how it works, the teams will come in, they will be accompanied by Ms. Menu. We have a panel here of experts and judges. The students have been prepped, they know that during their round they can ask 3 questions, and any of the judges and experts in the row, if you feel comfortable to answer that question, you are more than welcome to do so. I'm going to hand you out files now. I please ask that the judges and experts keep the files closed, because all of the scenarios are in there and we don't want it shared widely. And then I trust students' integrity, that if you are not participating and you are awaiting your round, that your integrity will apply and that you will not watch this online and that you will not be in the venue, so that if your team wins, it's a fair competition. And yes, thanks for that. I think that's everything I wanted to say. Maybe as a last thought, I attended the first ever Masters of Resus conference that was held in Joburg, and a lot of the people here today as experts and judges organized that conference. And when I walked up to the coffee and tea break room, I saw this poster there. And I want you to take some time today and just come and read the definition that was authored by the Masters of Resus Executive Committee about what a resuscitationist is. And I hope by the end of today that somewhere in that you will see yourself and that you will take that on your journey in becoming a healthcare professional. Thank you very much. Okay, so the teams can please leave now. And then team 1 and 2 and 3 can meet with Ms. Meno outside whilst I prepare the judges and experts. Thank you. Ladies and gentlemen, judges, experts, so we're going to do this however you prefer. I've prepared files for every one of you with the scenarios in it, as well as the marking rubric. So we need at least 3 judges for each round. Then Vian Viljoen, he's an MBCHB student there in the back, soon to be a urologist, I believe. Wanted to do emergency medicine, but got scared of it, so maybe Johan and Dani can speak with him afterwards. I need 3 judges, and Vian will then collect the marking sheets from you. So you can take turns. For the one round, you can be a judge, then you can sit out, and if there's a question from the students and you feel comfortable to answer it, then just raise your hand, we'll bring you a mic, and then you can advise them. So you'll be like the consultants of the firm. Any questions? Okay, perfect. Maybe I should just introduce you. So we have Dr. Melinda Sebastian down here at the bottom. She's from critical care at Steve Biko and the University of Pretoria. Then Dr. Safas Rousseau, he's our forensic expert for the day. And we look forward to the round where his expertise are really going to come to light. Dr. Liesel Bosenberg, she's our sonar hero, or our sonar doyen. At the University of Pretoria. Dr. Leanne Frankie, she's now in private practice. She's an anaesthetist. I never get it. Anaesthetist, anesthesiologist. Is there a difference? They're very clever. They gas people. Then Dr. Singh from surgery. I believe she recently just completed her fellowship. Is that the correct word? And she's now a surgeon, so welcome. Looking forward to hearing from you. Mr. Buys from Netcare, alumni of the University of Pretoria. Dr. Dani van der Merwe runs numerous emergency departments in private healthcare sector in Gauteng. Thank you for your expertise and experience. Avid pilot, so I think if we can get that simulator up and running, you'll be able to fly it for us. Then Ms. Kaji, she's a trauma nurse, very involved with snake bites and philanthropic work in South Africa. Thank you so much for joining us. Dr. Johan Horen, did my first ever P1 with him. Patient survived without neurological outfalls, went home. You remember him? Ja, hulle het hom plat gespuit pre-hospital en toe tube jy hom. Ja, that one. Then Caleb Lachny, also a dear colleague, very experienced emergency care practitioner, and he shared a lot of ideas and critical thoughts at the EMAT course in last year with some of our staff. Sean Groom, also part of the UP family now. He's from Mr. First Aid. They provide us with a lot of equipment, and they generously sponsor whenever we need something for the students. And then Sean, I'm not sure if you're going to judge, but Sean Skuman here in the front. He's one of the emergency care practitioners flying for rockets. And I suppose he's part of the team this afternoon. So, yeah, I'm not going to hand out the experienced files now, because ek het nou baie amper nie gedink nie. No. So, I'm going to go with the undergrad files. All right. If there's any questions, please feel free to ask me. This is your mic if you want to.
Right. Good morning, colleagues, ladies and gentlemen. I present to you Team 1, and they are resuscitation rangers. Yeah. So, thank you.
Good morning, team. Good morning, everyone. Okay, so I'm going to be telling you about your patient this morning. Okay, your patient is a 34-year-old male that was brought into the emergency room by EMS with a history of being involved in a motor vehicle accident. It was a high-velocity accident, and he was an unrestrained driver. He was extricated from the car, but sustained a traumatic amputation of his right leg, and bruising and bleeding over the right temporal region, with a decreased level of consciousness. According to another passenger in the vehicle, the patient has no history of other illnesses or any medication use. Thank you. Please go ahead, help your patient.
Okay, team, prepare for helping the patient. Pulse is present. Can we please get you on airway, Michelle? Can you put on the monitors, please?
I think we should restrain the blood here.
Okay, please get on that. Can we get IV fluids as well as soon as possible? Michelle, can we maybe lower the bed, please? Thank you.
Can we get a pulse oximeter as well?
Michelle, can we also stabilize C-spine when you manage? Okay. Patient is tachycardic. No BP cuff. Can we get the BP up and running, please? And SATS monitor.
Some bandage and gauze.
You can start, please. Thank you. Can we get IV fluids up running, please?
Fluids? What fluids?
We can get bloods, please.
Blood.
Michaela, I want you to stop. I want you to put on the AED, please.
AED. Team leader, can I have H's and C's help me with the bloods? Thank you.
Patient is pulseless. Can we please start CPR?
Can you please lower the bed on your side? Starting CPR. There's still a pulse. We can't begin.
Okay. We've hold CPR.
Team leader, do I still need to patch him up?
No, it's okay. Thank you. Can we get IV fluids up and running, please?
What other IV
Thank you.
fluids should I put up?
That's okay. Thank you. Can we check a pulse, please? Thank you, Michaela.
Team leader, restrain the bleeding.
Okay, patient is pulseless. Can we start CPR?
There's no pulse.
There's no pulse.
Yeah, you guys.
1, 2, 3,
Yes, please start AED.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 2 breaths given.
Chips,
1,
can you please
2,
prep emergency
3,
drugs?
4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23.
You first.
Are we clear, Mr. Gifford?
We're not here yet.
Okay. 1, 2,
Please check that pads are applied correctly.
Currently applied.
11, 12, 13, 14, 16, 17,
Thank you for good CPR.
21, 22, 23,
40 seconds left before switching.
29, 30.
Working, can I use the
Did you switch it to AED on the monitor?
Yes, I did.
Okay.
I did switch it
Thank
to
you, Michaelu.
AED. There's some technical difficulty.
Okay, thank you.
Apply pads. Analyzing
Switching.
now. Do not touch patient.
Are we clear? Should we clear?
No, not yet.
Pulse
Apply
is still,
pads.
pulse is still absent. Please continue CPR.
1, 2, 3, 4, 5, 6,
Chips, can we get an LMA?
9, 10,
Thank you.
11, 12, 13, 14, 15, 16, 17, 18,
Time down.
19,
Thank you.
20, 21, 22, 23,
Continue.
25, 26, 27, 28, 29, 30. One, two, three,
Team leader, should I still apply?
Please, please.
25,
Chipper, can we get after the next round epinephrine, please? 1 milligram IV. We're going to wait for shock.
Analyzing heart rhythm. Do not touch the patient.
After the second shock, we're going to give the epinephrine.
Apply pads.
Yes, please.
Analyzing now. Do not touch patient. Shock advised. Charging. Do not touch patient. Shock delivered. Paused. If needed, begin CPR.
Continue CPR, please. Stop CPR, please. Heart rate is back. Continue breaths. Can we continue H's and T's, please?
Team leader, anything I can help with?
Can we get blood tests, please? ABG. G. Yes, we have blood up and running. Thank you. We need to prepare patient for emergency surgery to stop blood.
I'm getting the blood.
Chips, did you request an e-fast?
Yes.
Can we get an e-fast, please?
Blood has been taken.
I think we have an open fracture here.
Team, BP is crashing. Can we assess airway? Airways assessed. Breathing. Can we listen to the lung sounds, please?
We need an intercostal drain. I think there's an
Apply
pneumothorax.
pads. Analyzing now. Do not touch patient.
Yeah, we have decreased area entry.
Apply pads.
Okay. Requesting intercostal drain.
Okay, guys, we're going to call it. Congratulations, Pulse. Thank you very much. Thank you.
Thank you. I need to break this off.
He's pretty good at picking up mostly everyone, but if the
I think we were so excited for the first scenario to start. We only introduced them by their team name, so I'd like to take this opportunity and have themselves introduce themselves individually and also what they're studying. And yeah, thank you very much.
Good morning, everyone. My name is Stefani. I'm a fifth-year medical student.
Hello everyone, I'm Ashish, I'm a first year sports science student.
Hello, my name is Unati Duan and I'm a fourth year nursing student.
Hi, my name's Chiba. I'm a fifth year medical student.
Hi, my name is Michelle. I'm a second year student.
Hi, my name is Mugelo Shongwe. I'm a second year medical student.
Go and relax, and please remember to watch out for that call if you should return for the knockout round. Okay? And you can join us now. Your scenario is finished, so if you want to stay, you're more than welcome. Judges, experts, anything from your side? Vian is preparing a very intense spreadsheet there. Results. We're not going to do a debriefing after every team. We'll do one just before lunch. And then, as I said, we will provide the students with support should it be needed. Emotional support. Other people will do that. We will provide medical emergency support, but the emotional support, we have qualified people that can do that. You guys are not doing it.
Right, second team. We are having engineers on call. So I'm going to let them introduce themselves and tell us what they are studying.
Hi everyone, I'm Abigail Murefu and I'm a final year nursing student.
Hi, everyone. My name is Hope, and I'm a second year PCMP student.
Hi everyone, my name is Rifilo Matima and I'm a second year medical student.
Hi everyone, my name is Botelo Madonsela and I'm a second year medical student.
Hi everyone, my name is Junyankos and I'm a second year PCMP student.
Hi, my name is Folakemi Olaokun and I'm a final year medicine student.
Hi everyone, I'm Vanda. A apparently I must introduce myself as well. Okay, so I'm from the Skills Lab. So guys, I'm going to prep you on your patient. Are you ready? Okay, so you have a patient. He is a 35-year-old male. He was brought into the emergency room by EMS with a history of being involved in a motor vehicle accident. It was a high-velocity accident, and he was an unrestrained driver. He was extricated from the car, but sustained a traumatic amputation of his right leg. And he also has bruising and bleeding over the right temporal region with a decreased level of consciousness. Okay. According to another passenger in the vehicle, the patient has no history of other illnesses or medicine use. You can continue to help your patient.
I just want to get gloves. Let me just wash my hands, sanitize, and get some gloves. Thank you. Hello, 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 hello. The patient is not, he's not responding, he's only making groans. He has a pulse currently, but it's very weak. I just want to listen for breath sounds. He's not, hello, hello, he's not responding anymore. Can we please get the resus team on hand? Okay, he only has breath sounds on the one side. Can we please get the resus team? Can we please connect the monitors for the patient? Can you please connect the monitors? Okay. Can you please connect the monitors? Can you please get an IV line access? Can you please hang emergency bloods and do a tap and screen for the patient? Okay. The patient no longer has a pulse. Can you please start with CPR? And can you please connect the monitors? And can you please start with airway? Can you please give him 100% oxygen? Can we please start? Make the bed flat, please.
IV lines administered.
IV lines in. Okay. Never mind. He still has a pulse. The monitors are connected. His heart rate is 138. Do we have a SATS monitor on? Hello? He's not just. We have 100% oxygen on. We have our airway things on standby. Can you please hang the bloods, the emergency bloods? Okay.
Emergency bloods administered.
Okay, that's good. Can we get a second IV line on the patient? Can we please control the bleeding? Can we please get more bandages? Can we please... Okay. I would like to call trauma. I want to know if we can put a...
I would like to call the trauma
Hello. I know the patient amputated his right leg. Is there anything he can do to help with the bleeding? It is bleeding currently. Can we please apply a tourniquet? No, I haven't applied the tourniquet yet.
Do you have a tourniquet?
Yes, we do have a tourniquet. We do have it. Okay, we're applying the tourniquet on the patient. Is this all that we can do, or can we do more? Any drugs we can use?
Well, I think at this stage the patient needs fluids and blood.
Okay, we already have fluids and blood on the patient currently.
Okay, where are you?
I'm at, I think, Tuelopele ICU, emergency room.
Well, I think you need to control the bleeding and get the patient to a trauma center as quickly as possible.
Okay, we will. Can we also call the... Okay, can we please start the secondary survey on the patient?
Okay, there are no bumps, there are no depletions on the scalp. There's a laceration on the forehead, on the right forehead. There are no any raccoon eyes, no bleeding, no epistaxis, no oral pink oral mucosa, and then tracheal, there's no tracheal deviation.
The patient is crashing. Can we please start CPR as soon as possible? Can we start CPR now? Can we please put a face mask on the patient so we can ventilate him?
Can we have arterial blood gas, please?
Can we please get an ABG? Good compressions, Hope.
Cyanosis, no sign of hypoxia as well. Then I'm going to expose the
Okay,
patient.
good breathing on the patient.
Peripheral cyanosis, negative as well.
Is the blood gas ready? Good job with the LMA. Can we please check? The blood gas machine is broken. Can we please check if he has a shockable rhythm? He does have a shockable rhythm. Can we please check rhythm? Good job with the breathing. Good job with the compressions. One breath every 5 seconds. Good job. Can you please check the rhythm? The rhythm is a ventricular fibrillation, so it is a shockable rhythm. So we'll apply a shock as soon as possible. Can you please charge the defib? How much time do we have left? 45 seconds left. So we're going to switch in 45 seconds. We're charging our defibrillator. Can we please, everybody clear from the patient? Oxygen clear, everybody clear? Shock delivered. Can we please carry on with CPR?
26 seconds left.
There's no chest trauma to the patient.
Can you
There's
please,
no toxins as well.
can you please assess the pulse? He has a weak pulse back, but he has a bradycardia. Can you please give 1 amp adrenaline?
10 seconds left.
Are you okay with the compressions, Hope? Do you need to switch or are you fine? Good job with the compressions. Can we please stop with the compressions? He has a pulse now, so we'll just continue with post-ROS care. So we have a second survey. We need to call the general surgery and the trauma surgeons just to take care of the patient. Is the blood gas not coming? It's not coming. Okay. Can we please do 4 more bloods on the patient? So we need 4 more bloods. We need HB. We need a FBC, UNE, CRP, and can we please check with the EFOS for any tamponade or any pneumothorax, hemothorax? He has a bit of a tachycardia. Can we please give atropine or EFAST? Anything on the EFAST? Does he have a tamponade? Does he have anything on the EFAST? Does he have anything on?
So no cardiac tamponade, no.
Does he have anything? We did an EFAST on him. Does he have a tamponade or? Okay, everything's negative. Okay, so there's no bleeding intra-abdominal. Okay, that's good. Did we give the atropine? Okay, atropine was given, but he still has a tachy. Can I phone an emergency medicine doctor?
I would like to call an
Well, I'm still holding on the line.
What can I give him to reduce his pulse? He has a tachycardia right now.
Well, why does he have a tachycardia?
He's bleeding. We are giving him blood products, but also we think he might be in shock.
What's his other vitals?
We don't have a SATS, even though the SATS probe is connected, so I think our SATS is broken.
Okay, well, I think, have you instituted the massive transfusion protocol?
We called for emergency bloods and we did a tap and screen, but okay, we will can we please institute the massive transfusion protocol?
Okay, do you have a surgeon immediately available?
We called for one, but none have arrived.
Okay, I think we're going to send a rocket to you to come and fetch the patient. So I think you need to prepare the patient for transport. So
Okay.
Is the airway secured?
The airway is secured.
Okay. You've got 2 IV lines going.
We've got 2 IV lines
The
running.
blood's going.
We've got blood.
You controlled the bleeding.
We have a tamponade. We have a tourniquet to control the bleeding.
Okay. Well, I think the tachycardia is probably due to the adrenaline that you gave and compensatory, so just leave that alone.
Okay.
Okay, guys, we're going to call it. Thank you very much. Well done.
I don't know what to do. Let's go.
You read the team name? Yeah, I did.
Okay, thank you. Yeah.
Ladies and gentlemen, as everything emergency, we are running ahead of program. So we've just informed teams 1, 2, and 3 that they should join us after this session, and then we can do a quick debrief with them. So think about things that you've noticed and you want to discuss with them, maybe some questions, compliments, and yeah, thank you very much. Zanik, how many people do we have online? Thank you so much. Maybe you should say to me in person in my ear, just maybe now it's 1 and then I feel terrible.
Revive you!
Woohoo! Wow. We have a revival rock stars, and then I'll let the team leader introduce her team members.
Good morning, everyone. My name is Shanalee Bester, and I am a fifth-year medical student here at the University of Pretoria.
Good morning, everyone. My name is Kanyisa, and I'm a BCMP third-year student.
Hi, everyone. My name is SimUPWars, and I'm a second-year medical student.
Morning, everyone. My name is Dalen Chakane, and I'm also doing medicine second year.
Morning, everyone. I'm Weti Mugudi, and I'm also doing second year medicine.
Morning, everyone. Anele, nursing second year.
Good morning, everyone. I'm Vanda from the Skills Lab, and I'm going to be prepping you for your patient today. Okay, so your patient is a 34-year-old male that was brought into the emergency room by EMS with a history of being involved in a motor vehicle accident. It was a high-velocity accident, and he was an unrestrained driver. He was extricated from the car, but sustained a traumatic amputation to his right leg. He has a poorly applied pressure bandage on there. He also has bruising and bleeding over the right temporal region with a decreased level of oxygen. According to another passenger, the patient has no history of other illnesses or medicine use. Please help your patient.
Okay, do we get told when to start? Okay, guys, we heard from the EMS, we have a trauma patient. Okay, please can we start getting monitors on? Please can we just make sure that his SATs are good? Can we get monitors on so long? Blood pressure cuff is already on. Can we make sure that we get 2 drips, please? We just want to take care of the bleeding as well. So can you please just take care of that? Can we apply some pressure? Make sure that we stop the bleeding. Can we get the SATs probe on as well? Can we just get the SATs probe on so we can check his breathing? Daisy, can you get the SATs probe on for me first, please? Okay, we have a good heart rate. Okay, how's the bleeding? Okay, applying good pressure there. Okay, it looks like the patient's desaturating a bit. Can we please change to a bag mask?
Changing the bag mask.
Okay, my team is donning the appropriate PPE in this situation as well.
Changing the bag mask.
Okay, please hurry. Okay, can we lower the bed?
Oxygen. It seems that I'm not getting a good chest rise. What to do?
Okay, can we, if there's no chest rise, okay, can we then put an LMA in, but can we lower the bed before we do that, please? Can we also, while we're here, just call surgery so that they can just come and help us prep the theatre so we can manage this leg? Okay, can I get someone to run a blood gas? I also want to call that they get chest x-rays done so we can see if there's any further damage. Okay, have we lubricated? Thank you.
In. Connecting to every bag. There's no pulse.
Okay, no pulse. Please can we start CPR?
Starting CPR.
Please can we apply the pads? Good CPR. Okay, please continuous compressions and then continuous breaths, please.
Continuous compression stem.
Okay, can we put on AED?
Apply pads.
Okay, can you just make sure the pads are on properly? Like stick it to the skin as well.
Shanali, your surgery consult is online. Surgery?
Apply pads.
Hi.
Hi, tell me about your patient.
So my patient is a 34-year-old male. He was part of a high-velocity vehicle accident.
Okay.
He does have an amputation and other possible injuries. We have asked X-rays to come now. We will send him for his X-rays as soon as he's stable.
Your current vitals?
Current vitals. We are doing chest compressions. Potentially going to be shocking soon.
Okay, tell me, he's obviously was shocked before that. That bleeding, have you controlled it?
Currently, no. We were in the process. Can you please apply pressure to the wound?
Yeah, so if the pressure doesn't work, please apply a 20K.
Sorry?
Please apply a 20K if the pressure is not working.
Perfect. Thank you. We'll do that. Okay. Can you apply the tourniquet? Can we also order some blood in the meantime so we can transfuse?
What rhythm do you have so far in your CPR?
Right now we have a VFib.
Have you shocked?
Guys, please make sure the pads are sticking properly. Daisy, just make sure it's sticking.
Apply pads.
2 minutes, done.
Daisy, the pad there is not sticking to his body.
Certain compressions.
Okay. Do we have the results from the blood gas that have come through? Machine's broken. Okay.
Apply pads.
Okay, good job on the CPR. Good job on the breaths.
If needed, begin CPR.
Okay, let's continue CPR. Okay, I don't know anything about his blood pressure. He's in a...
Breathe.
The machine's broken. Can you start your secondary survey quickly while we are busy waiting to see for the shock? Please administer continuous breaths. Don't pause.
30 seconds left.
Breathe. Breathe.
Okay, as you go, can you tell me what you're finding on the secondary survey? Okay. Can someone please just call Nero that they can come and have a look?
2 minutes done.
Discharge in his ear, nose, mouth, and some breathing.
Continuous breaths.
Just make sure, is it sticking? Okay, how are we
Is
looking
there
for
Nero
time?
consult in the room? Nero wants to take a Nero question?
Okay, perfect. When does pulse check?
Apply pads.
When does pulse check?
Guys, I'm the technical team. Your defib is malfunctioning. Please use the AED.
Okay, please remove those pads, put the new pads on.
Thank you.
Okay, just be careful. Get the metal part.
Apply pad. Plug in connector.
30 seconds left.
Okay, good compressions. Just move a bit down, please. Thank you.
Apply pad. Plug in connector.
Okay, while she's applying the second pad, can you plug in?
2 minutes done. Time's up.
Okay, stop, swap, let's analyze. Please check the pulse for me. Daisy, please check the pulse.
Apply pad. Replace pad.
Is there pulse? Okay. This on. Can you put it off?
Press pads firmly to patient's bare chest.
Okay, good CPR. Good compressions. Continuous breaths.
Analyzing heart rhythm.
Okay, please stop compressions.
Don't touch the patient.
Clear?
Shock advised. Charging. Stay clear of patient.
Okay, everybody clear?
If needed, begin CPR. Shock.
Okay, and shock. Okay, please continue chest compressions.
Doing chest compressions.
Start CPR.
Okay, can we give 1 milligram of epinephrine, please? Thank you.
Seconds left. Continue.
Okay, the saturation's not looking great. Okay, do we have a pulse? Can we just do a pulse check? Okay, the heart rate's very high. Can we please give adenosine for the heart rate? Okay, is there a pulse? Okay, can we please maintain the airway? Okay, we just want to warm the patient, have a look at the blood pressure. Okay, saturation is picking up slightly. Are we in the lungs? Can you just check for me if we are in the lungs? Make sure. Okay, so we just want to make sure with the blood pressure if we need to actually transfuse any blood at this stage. Can we just make sure the patient is nice and warm as well? If you can put a heating blanket over him, please. Okay, can I also then just get a 12-lead ECG, please?
Thank you, guys. We're going to call it. Your patient has a pulse. Thank you very much.
Guys can take a seat. And then I would love your scribe notes. Thank you so much. So go and relax. We're going to chat now.
It's fine, guys. You can have a seat. Thank you very much. Well done, eh? Well done. Thank you. Thanks.
Sorry, guys. I got flustered with the... I think I should have done it while we were waiting. You should have said something.
I'll just do it in there.
Okay. So, whilst they are preparing the patient for the next scenario, one of the things I just want to mention is that we seem to be having technical difficulties, but I think there are various options available if one of your equipment malfunctions. So that's certainly something that we can address during the debriefing. Are all three teams here? All right. So let's start off. Are we going to do this AHA style? Positief, negatief, positiewe broodjie. Lekker. Okay. So, in terms of team 1, let's hear from the judges, experts, even the audience, something positive that the students did. Caleb. Caleb, maybe there should be a mic by you, guys. Perfect. Thank you.
Hello. I think just being willing to stand in front of a group of people you don't know and participate in a sim is quite intense. So I think that's really, really well done. And then also a lot of times the recognition that you need a little bit of additional help, it came in quite early. So that's awesome. The CPR we've been seeing is unbelievable. I don't know who taught you CPR, but wow, good job.
Okay, something that you thought team 2 or team 1 can improve on. Dr. van der Merwe, Sean, you guys can just pass the mic there.
I don't know if you guys obviously did your CPR amazing as actually all 3 teams, wow, recognize, start and everything, but your closed loop communication, so you guys have to start focusing on that as well. Use your team members, use your teammates, and then address it initially, because it looked like you guys all know what you're doing, definitely, but you're just standing there, and then the team leaders, you would like state, listen here, I need a blood gas. Who must do it? You understand? You have to recognize, you have to focus, and that team member must reciprocate that as well. So that is just something that they can work on. It's nothing bad. I think you guys are still working on a lot of stuff, but yeah, it definitely helps in the team environment. And then, Mr. Groom.
I think what's also important is that we need to identify the CABC process. All 3 teams have missed that completely. And I think C standing for catastrophic hemorrhage. It's no good addressing everything else if we have allowed the patient to exsanguinate on our resus bed, because we cannot phone the consultant and say, we're busy with X, Y, and Z, and he has to tell us to put a tourniquet on. So that's part of our systematic approach. So C standing for catastrophic hemorrhage, then airway, then breathing, then back and reassess circulation. So that's very, very important.
Thank you very much. I think that applies to all 3 teams, like Mr. Groom said. Let's move on to team 2. Is there anything relevant or pertaining that the judges and experts would like to share with team 2? Dr. Singh.
Is it on?
Zanik, Dr. Singh, can you switch her on? Thank you.
Okay. Yeah, I think, again, I think all the recesses were pretty good. Just the second team, I think the energy was great. I think you need a strong leader like that to lead a recess, to pick up things quickly and to delegate quickly. So I think that was really well done with the second team. The only issue, I think, with the second and the third team is secondary survey. You need an alive patient, a stable patient to do a secondary survey on. So I think just that's a take-home message. Primary survey, that's your goal. You save the patient. Secondary survey is someone who's sorted, you're ready to transfer, now you're just looking for other small things. Those are not life-threatening things. When you have no pulse, you don't look for abrasions, you don't look for other things. So I think just save the patient, that's the message. But the energy in the second team was great.
Thank you so much. Well done, guys. Yes, sister?
I'd just like to say that everybody missed assigning team roles, and I think that's very important before you even start your resus, because then you get good direction of who's doing what, and yeah.
Thank you very much. Anything that's pertinent to team 3 that you want to mention?
I know there was a hiccup with the monitor. What's important just to put in the back of your mind, you could have stated it, was early defibrillation. I think we were all wondering when, and I think one of the other panelists asked the same question, have you defibbed the patient yet? And no one could answer that. So early defibrillation is important. The sooner we give it, the better. And then there's a very, I think Johan and I mentioned it now, when do we give atropine? Everybody seems to be giving atropine at a heart rate of 188. So I would encourage everybody here to come in and join Caleb on an epic ACLS course. So that would be good.
Thank you. Dr. van der Merwe, it looks like you have something to add.
Well, yes, I think, again, good CPR for everyone. I think it's just important to make the transition to advanced life support as quickly as you have established your BLS. Identify an early need for transfer. I think that's probably the cornerstone of ATLS. Get an expert involved, because, I mean, to get a transfer done to a proper facility takes time. So you need to identify that right from the beginning. And then, like Sean mentioned, I think drugs has got very little place in the acute management of trauma, certainly before bleeding control. So drugs is a last resort, but in terms of basics, in terms of bleeding control and fluid administration. And it's not, this whole thing nowadays about hypertensive resuscitation of a MAP of 60, that's fine. We all get very nervous when the patient's blood pressure is low. But if you've got an exsanguinating wound, a low blood pressure, as long as there's central perfusion, is saving the patient's life. If we give adrenaline before we've controlled the bleeding, we're actually going to make it worse. So just hold off on the drugs a little bit until it's really part of the resuscitation.
I think that's very valuable advice. Anyone else? Before I hand over to the teams, I would really love to hear from them as well. Your experience, and now it's your opportunity to give us a sandwich. Positive, negative, positive. So the Skills Lab, join me here in front so that you can get your feedback. Sorry. Of course,
Yeah,
of
while
course.
you guys are coming down. I just wanted to also say, you all asked for a blood gas. What was that going to change about your treatment? So don't do a test if it's not going to change something. If you want to change something and there's something that you're looking for to go and fix, it's a great idea to go and look for it. But what's that blood gas going to tell you? It's going to tell you he's in trouble, but you knew that already. Cool.
Okay, guys, very valuable advice. I hope you make notes and remember this, even if you're a first or a second year and you haven't even completed your anatomy module yet. This is basic physiology. If you don't get the basics right, certainly you're going to struggle with the pathology. And I think this is what every one of you see here, is that attending classes in this side of campus, where the basic medical sciences, very, very important. Love to hear from the teams. Team 1. Just use the mic. Thank you.
Hello. Just want to say thank you so much for everyone that came here and for the learning opportunity. It was really fun. Thank you.
Anything that we can do different next year?
Maybe if we could have another additional practice session. That would be quite nice. Okay. Thank you.
Thank you. Team 2.
Thank you so much for the opportunity to learn and for taking time out of your day to be here and to judge us. I think my only other thing to say is because we were given assigned team roles before we came, in all of our practices we've already had team roles, we probably didn't see the need of designating, being like, oh, hey, Hope, you're on breathing, because she already knows she's on breathing. So I think that should just be taken into account. But also the other practice session would be nice, just so we can have more time to familiarize ourselves with the team.
Thank you. Team 3.
Sorry, I'm here at the back. I also just want to thank all the professionals and even the people watching for taking their time to be here today. I think it just highlights the importance of a competition and a situation like this, because I think we all came in feeling very prepared for today and we know what we're going to do. And then as soon as it actually happens, and this is a simulation, this isn't even real life, you almost go blank and you have no idea. So it really just reinforces how important practice is, and to put yourself in these situations and to learn from them, so that when you encounter the situation again, or maybe in real life one day, that you will do things differently and do things better. So I think today it just highlights the importance of practice and exposure. So thank you, Prof, for organising this, and thank you everyone who's here to help us.
Thank you. How are we for time? Have we caught up a little bit? What time is it now? Okay, so let's take a 10-minute comfort break. And maybe, 7 minutes, sorry. Is there anyone else from the audience that would like to add anything? Yes, sir. Please do.
Second years.
Maybe just say your name and what you're studying.
I'm Kagiso Ratsafola, third year med student.
Okay.
For the second years, please clear the oxygen before you deliver the charge. So, because I saw that you did not clear that. You cleared the patient, but then you leave the oxygen bag inside. Then that's bad. Just gonna burn.
I just want to ask on that point. Attending Master of Resus has opened a couple of very important questions for me, of which one is there actually a study that proves that the oxygen ignites? Is the charge or the arc or whatever, however electricity works? Caleb, can you please tell us if that's true?
So with pads on, you have like a 0.01% chance of starting any kind of fire. I think the big areas for risk are in theatre, where you have volatile gases and where you have diathermies, and you've got a whole lot of other stuff involved. But in the defib environment, so long as your oxygen is not pointing at the pads or at the pedals, nothing will happen. And I don't have a study, but that's how I do it, and I have never ever seen a fire spark, nothing.
What does our anesthesiologist think?
Thanks. The biggest thing is in theatre, and even then when we defib, we just keep the circuit complete. So it's when you're actually disconnecting that you're causing trouble.
So if the patient's intubated and ventilated, just leave it as
leave
is.
it. You just step away from the patient.
Okay. Yes.
It's going to be on the stroke side in any case, on the operating field. It's not going to be on the anaesthetic side. So I think it's so far away that it's really not major. All the fires that we've seen is basically from the diathermy and from CO2 that's in cardiothoracics.
Okay. And if you guys don't know what a diathermy is, you can come and visit us in the Surgical Skills Lab. We'll show you what it looks like. Okay. Thank you very much, guys. You're more than welcome to stay. There will be vouchers available for all the teams that participated to enjoy something at Crisp. And then I think for now, maybe stretch your legs for 5 minutes so that we can start at 10 sharp. Thank you so much. Welcome MBCHB2. Everyone is welcome, so please post on your class groups. Let's fill this venue up. We can even start a competition and see who has the most members in attendance that's not participating. Seeing that I'm a nurse, I'm rooting for them. Sorry, doctors, BCMPs, physios, radiography, OTs. There's no one here rooting for you. So please post on all the groups. Let's get the nurses here. Everyone comfortable and ready? Then we are going to welcome Team 4. You're welcome to come in. No, come in. It's very informal. This is not the professional pillars of professionalism class. Please join us. Do come in. Rod, we ready to go? Rod is the body, mind, and soul of this sim man. Everyone ready? We're busy with the blood pressure. I hear it. Well, okay, let's just see, waiting for 2 judges. Okay, Femi, whenever you're ready. Thank you. Everyone ready? Let's go.
Hi everyone. It's morphin time. Boom 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 boom. Boom boom. All right, welcome back, ladies and gentlemen. I have Pulse Force, and then they're gonna introduce themselves. Okay. Yeah, so we are Pulse Force, hence the lightning bolts. My name is Nomgabo Vika. I'm the team leader. Next to me, we've got Sitati. She's a BCMP second year. She's going to be on airway and breathing. Next to her, we've got Valni Marit. She's an MBCHB3 on circulation. Next to her is Wandile. He's MBCHB2. He's our drugs and defib guy. Next to him is Yavar. He's also MBCHB2. He's our H's and T's. And then we've got our scribe, Timu. He's MBCHB5. Right, thank you.
Good morning, everyone. Can you hear me? Okay, I'm Vanda. I'm from the Skills Lab, and I'm going to prep you for your patient. Okay, so listen up, guys. Your patient is a 34-year-old male that was brought into the emergency room by EMS with a history of being involved in a motor vehicle accident. It was a high-velocity accident, and he was an unrestrained driver. He was extricated from the car, but sustained a traumatic amputation to his right leg that currently has a poorly applied pressure bandage to it. He has bruising and bleeding over the right temporal region with a decreased level of oxygen. According to another passenger in the vehicle, he has no medical history and not currently on any medication. You can go ahead and help your patient.
Okay, I'm observing for any hazards. My team and I will then don on our PPE. Hello, sir. Hello, 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 hello. Is it? Hi, sir. How are you? Okay, so can I please have my team come in? Airway, can we please help him breathe? And I need my monitors on. H's and T's, please control the bleeding. Yes, he does. Patient has a pulse. Monitors. Stats, please control the bleed, H's and T's. Valni, please help with the controlling of the bleed. Where's my monitors? I need my monitors, guys. Okay, blood pressure is 80/39. There's no pulse though. Yeah, there we go. Monitors. She doesn't have a pulse. No pulse. Start CPR, please. No, there is a pulse. There's a pulse. We have a pulse, guys. Wait. Continue what you were doing. I need an IV, please. Running ringers. Okay. Blood pressure is 80/39. Blood pressure is very low. There's no heart rate. Put up a second line. There's no heart rate. Valni, please check for a pulse. I need my monitors, guys. SATS probe. H's and T's, please help with the SATS probe. Yava, can you please give 1 gram TXA? Okay, what's the rhythm? Unshockable. Tachycardic, it's fine. Sats is dropping, blood pressure is still low. Valni, is that bleed controlled?
Yes.
Okay, it's tachycardic. We don't have a saturation. Sats are low. Administer oxygen, okay. Change. Okay, bag mass. We don't have a pulse. Valni, please check pulse. Shock. Analyze. Are the pads on?
Clear.
Okay, continue. Okay, Wandile, can I please get adrenaline 1 amp? Flush. We've got a heart rate. It's climbing. Valni, check for pulse. But the heart rate is climbing though. We don't she doesn't have to do compressions, right?
No, she doesn't.
No compressions, Valni, stop.
There's no pulse.
Okay, we've got a pulse now. Saturations are very low. I need that oxygen, please. Is my BP cuff on? Okay, rhythm. What is that rhythm? So we're having a tachycardia. The SATs are climbing. That's good. Thanks, guys. I need that BP cuff machine, the BP machine on, please. I can't see the readings. It's SATs of 94. Should we still continue? He's still tachycardic with an abnormal rhythm. I think we should cardio it. Okay, guys, we've got good BP. The BP is climbing. Heart rate is, he's still tachycardic. Sats are increasing. And how is the bleed? Have we controlled that? Okay, can we please do an E-fast to assess if there's any other injuries in the chest? Okay. Yava, do we have blood gas results? Wandile, please help Yava with the E-fast.
The E-Force tech is on vacation.
Okay. Okay, Yava, please start H's and T's. Okay, heart rate is decreasing. Thanks, guys. BP is low. So how is my line? Is it still running?
Okay, guys, thank you very much. We're going to call it. Patient has a pulse. Thank you very much. I'm so stressed. Okay, everyone, are we ready for the next one?
Right. Now the next team, they call themselves Bloody Angels and the Devil. So come in.
Morning, everyone. We Bloody Angels and the Devil. Basically, I'm leading them to hell, but we believe in everything and that the patient will live. This is Byron. He'll be doing airway and breathing. This is Anya Swart. She'll be doing H's and T's. This is Tswanso. He'll be doing circulation. And then Samanga will be doing manual defib and drugs. And Ashan will be our scribe. And I'm Niha Pillay. I'll be the team leader for today.
Just wait, guys, just hold up. I'm Wanda from the Skills Lab, and I'm going to be prepping you for your patient. Okay, so listen up. Your patient is a 34-year-old male that was brought into the emergency room by EMS with a history of being involved in a motor vehicle accident. It was a high-velocity accident, and he was an unrestrained driver. He was extricated from the car, but sustained a traumatic amputation of his right leg. He has a poorly applied pressure bandage to that leg. He also has bruising and bleeding over the right temporal region with a decreased level of consciousness. According to another passenger in the vehicle, he has no other medical history and not taking any medication. Go ahead and help your patient. Thank you.
Okay. I'm putting on my gloves and calling my resus team. Hello, sir. Okay, the patient is unresponsive. He's got a massive bleed here. I'm feeling for pulses. Yes, please apply pressure and a tourniquet if needed. He's gasping. Can you please get an airway, Byron?
Should I put on the monitor, team leader?
Yes, please.
Okay.
Thank you, Samanga.
Okay, leader tourniquet.
I can't feel pulses. I can feel a pulse. Okay. I can feel a pulse. Can we have pressure on the leg? And can we also have an orthopedic consult, please? Anya, can we please have an IV, 2 IV bore lines, an arterial blood gas and bloods? And so an FBC, UNE, D dimer, and can we have a cross match, please, and activate the massive transfusion protocol?
Monitor on, team leader.
Thank you.
Is there an orthopedic surgeon in the house? Consult.
Saturation kit on.
I only nail those that are living.
The bleeding. The tourniquet is on. The tourniquet is on. Yes. Byron, can we get an airway?
Team leader, can you please hang some fluids?
Yes, Anya's hanging the fluids.
Consider blood, please.
What can we?
Consider blood.
We ordered the cross match already and activated the massive transfusion protocol already. Yes. Samanga, can we please give the tranexamic acid, please, IV?
I'm switching over to a bag valve mask.
Anya, can we listen to his chest as well?
Headlocks, please.
Okay, Tswaso, can you please help with the immobilization while Samanga gives the TXA? On the left side, can we check for a mediastinal shift?
We have a rhythm shift.
Can we check if
That's the few angels. please.
Yes, can we please attach a manual defib? No pulse. Okay, start compressions. Can we please have manual defib or the pads on, please?
Agile is in. Gel, please.
Okay. It's a shockable rhythm.
Charge. 200 joules. Charging. Clear the patient.
Clear the oxygen.
Clear oxygen. Administering shock. Shock administered.
Continue with compressions. Can we switch to pads? Can we also please, Anya, can we please get atropine in, please, as well? Okay. Can we also please, in the meantime, start doing an e-fast? Thank you.
The e-fast is not working.
The e-fast is not working. Okay, we've got decreased breath sounds. Is there mediastinal shift at all, Anya? Yes. Can we also please consult trauma or get a trauma surgeon for the bleeding?
Is there a trauma surgeon in the house?
I'm not a trauma surgeon.
Dr. Singh?
Hi, yes. Can you tell me about your patient? Yes. Can you tell me about your patient?
It's a P1 patient
Okay.
involved in a head-on MVA with a current amputation of the left lower limb and decreased breath sounds.
Okay, what's the current vitals like?
Vitals are currently stable.
As in? What is stable?
Okay, so heart rate is 99, saturation 94. The blood pressure cuff is currently not working. But
Okay, how's the bleeding control of the limb?
currently with a 20K.
On a 20K?
Yeah.
Okay, great. Please arrange heli and transfer the patient. Have you done a secondary survey now? Just
We are
to make sure?
going to. Okay.
Okay, perfect.
Team leader, there's no breath sounds on the right side. I'll just confirm. No. Okay, can you please prep for a needle decompression of the right side and the intercostal drain?
Before we do drains, I'm going to stop you there. Your patient has a pulse. Thank you very much, guys. You can stop.
That was horrifying.
Okay. Yes, you can come in captured. Please, let's welcome them. So the team leader will tell us why captured and will introduce the group members.
Okay, hello. So we are captured, CAB, for circulation, airway, breathing. Our sentence is saving people's lives. This is Ndibo, he's our timekeeper. He's MBCH B2. Elmarie, she's on defib and drugs. She's MBCH B6. Divan, he's on airway, MBCH B2. Then we have Vusi, who's also on airway, and he's sports science 1. And then we have Mihle, who's our BCMP 1 student, and she's on H's and T's. And I'm Nicole, I'm MBCH B6, and I'm team leader.
Hello, guys. Guys, just listen up for a second, please, before we jump in there. I'm Wanda from the Skills Lab, and I'm going to prep you for your patient. Your patient is a 34-year-old male that was brought into the hospital by EMS with a history of being in a motor vehicle accident. It was a high-velocity accident, and he was an unrestrained driver. He was extricated from the car, but sustained a traumatic amputation of his right leg, and currently has a poorly applied pressure bandage to that. He also has bruising and bleeding over the right temporal region and has a decreased level of consciousness. According to another passenger, the patient doesn't have any other medical history or is not taking any other medication currently. You can continue and help your patient. Thank you.
Can we start? Okay, so I'm gonna don my gloves. Okay. Okay. Hello, hello. Okay. The patient's not responsive. Oh, patient is responsive. Okay, can I please have my research team? I would just like to attach monitors and see for vitals. Just feeling my pulse. Okay, please attach the blood pressure cuff, the SATS monitor. Okay. Where's... Trying to look for vitals. It says question marks. Okay, so I see the bleeding, so I'd like to apply a better pressure bandage. Can I please have, I don't know, pressure bandages? There's no vitals. There's no vitals. Okay, he still has a pulse. Can you please attach the SATS monitor? Mihle, please attach the SATS monitor. And the BP cuff, it's attached. Oh, okay, there's it. Okay, so the BP is low. Okay, attached. Is it attached? Okay, he's tachycardic. He's sat. Can we please put on? Okay, he's already got. Is oxygen flowing? Yeah. Can we please also have a blood gas? Mihle, blood gas. 2 large bore IV lines. No, his heart rate's still there. Heart rate's still there. Did you attach nasal, did you attach oxygen? Okay, large bore IV lines are attached. Can we please attach oxygen?
It is attached.
Okay, he's SATs or not. Okay, can you please put nasal prongs in? Nasal prongs. Okay, I'm gonna start. I don't know. Please, quickly. Okay, do we have the blood gas? Did someone take the blood gas?
So we're taking blood to cross-matching, typing.
The blood gas machine's broken. Okay. Sure. Okay. Okay, can you please write the time that I put on the tourniquet? Is it? Oh. Okay. Okay, I don't. There's no pulse. Okay, sir. Okay, please start. Okay, I'm gonna start chest compression. 2, 3, 4, 5, 6, 7, 8, 9, 10. Joel. Okay, so we don't have a black. Did you write when CPR started? Okay.
Clear to analyze.
Clear to analyze. Has the bleeding stopped?
Slow down.
Okay, it's slow down. Okay, we're taking too long. Is it a shockable?
Yeah.
Okay, so we have a shockable rhythm. Continue compressions.
Okay, clear.
Is shock delivered? Okay, it's fine. Carry on compressions. Okay, I think you just. Okay, so Agile.
Can I have the eye gel, please? Thank you.
Okay, his heart rate's back. Okay, his oxygen is still, please, quickly. Okay, his heart, let me just. Okay, H's and T's. Can we start the secondary survey? I feel like his pulse is bad. Have you reassessed the rhythm? Is there a pulse?
No. What's the time?
So there's no blood gas?
No, there's no pulse.
Okay. Can we please just start like assessing the head?
1 gram cyclic.
Yeah. Cyclocapron. So it's tranexamic acid. So we're giving tranexamic acid, 1 gram. At what time? Okay. Just record the vitals. Has the bleeding stopped?
The bleeding has stopped for now, yes.
Okay. Okay. Can we just assess? So was there any So we see the marking on the skull. So I'm worried about a skull fracture.
Yeah, 2 minutes over, guys. I'm giving you 10 seconds to switch. 6, 7, 8, 9, and you guys must switch now.
Oh, you carry on with the secondary, so okay. Is there anything coming out the ears or the nose? But he's got a pulse. I think we should stop. He doesn't have a pulse. I think we need an expert's help. What to do next?
Dr. van der Merwe from Emergency is online.
Oh, yes. Did you do a pulse check after 2 minutes when you stopped, swapped, and analyzed?
So she's on it. She did, yeah.
Just struggling with the pads to get them to register.
I think it's important when you stop, swap, and analyze to check the pulse for 10 seconds.
Okay, how many minutes do you have left? Okay, I think let's check the pulse.
Yeah, there's no pulse.
Okay, stop.
Don't maybe not check for a radial pulse. That might not be
I'm
present.
checking.
What are you going to feel if they check for a pulse while doing compressions?
I'm gonna feel it. But okay, stop the compressions.
Just relax.
Okay, there's a pulse.
There you go.
Okay, so you can stop chest compressions. So we have a pulse. Okay, so
I'm going to call it. The patient has a pulse. Yay. Okay. Thank you very much and well done. Okay. Thank you very much and well done. Okay.
Okay, thank you teams 4 to 6. And welcome to the new members of the audience. So we are going to do your debriefing team 4 to 6 in a similar fashion like we did teams 1 to 3. I do want to mention before we start that we do realize that we present the same scenario to all the students. And that is just in an attempt to standardize the learning and the marking. Certainly there is probably better ways, and for that we have educational experts that will be joining us later. And Dr. Frankish is actually busy with a postgraduate diploma in simulation, and Dr. Bosenberg completed one, if I remember correctly, in Scotland, in Ireland. So we will certainly consult with them to see if there are better ways if you have such a large amount of teams to standardize and ensure that students still get the same experience, but that everyone has a surprise. That said, I'm going to start with the judges and experts to give you feedback. Can we start with team 4? Feedback from the judges and the experts.
Okay, from 4 to 6.
Yes, from 4 to 6. So just there should be a mic close by if you want to give overall feedback. But if you have something specific now for team 4, then we can do that.
No, I've got a general view of what I saw from 4 to 6. I see hyperventilation. They all close their fist into the BVM, and I would like for them, as soon as they see chest rise, they can stop. I know some patients are difficult, but when it's necessary. But let's try not to hyperventilate the patients.
Thank you very much. Any other comments? Mr. Groom? First team to pick up TXA. Good. Okay. Cyclocapron. I can't pronounce the Tranik Sakazawaka Watts asset. Any other comments? Dr. Frankish?
I can't remember which team it was. I think it was Bloody Angels. They were the first team to actually maintain the C-spine, which is very important when you're managing the airway. You can take a non-paralyzed patient and make them completely paralyzed.
Okay. Any other comments? Dr. van der Merwe? Just check your mic if it's on.
These last 3 teams were all excellent. Good leadership. I think the last team, the leader was very anxious and hyperventilating, but overall, very, very well done. I think they were the first team to apply the tourniquet very early on, which is ultimately And I think one thing that I mentioned is that they ask for vitals while doing CPR. I think you should actually close the monitor while doing CPR until those 2 minutes are up. But when the 2 minutes are up, then you actually need to quickly check, do you have a pulse? And if you have a pulse, then do the vital checks. If I can just get that right.
Thank you. Dr. Singh?
Yeah, no, it was pretty much similar. I just wanted to say, because you asked for monitors, you need to keep checking it. Like, obviously not during the CPR, but if you need to assess response, you need to see, do I have ROSC or not? So I think they just, obviously it's a simulator, so they get a little bit frazzled. But I think just to keep reassessing, because you can't be doing, that was CPR on an awake, alive patient, basically.
Anything from the audience? Dr. Horan?
Okay, yeah. So just some general comments, and it's most of the teams. I think everyone's very much focused on the monitors and looking at the monitors. I want to advise you to look at your patient and treat your patient. That's going to help you a lot more. And then important to go systematically. So start at a point and follow through. So I think it's a general thing again. But start at a point and then check again, has your interventions had success? Like with the bleeding, has your intervention had success or move to the next step? And that's a general term. Same with the oxygenation. Do something, look, is it better? And then proceed onwards. And then also, in terms of the teams, help your team leaders to communicate back, give feedback, say, I've done this. So that's a closed loop communication. All the team members have been very quiet. So give feedback to your team leader and tell them what you're doing, what you've done, and so on, just to help them a bit more. Yeah, I think that's the big stuff. The communication a lot and going through the systems of the patients.
Thank you. Can we hear from the teams? So we'd like your feedback in terms of your experience, and then we would also like to learn from you. So anything that we can do different for next year or better, please also advise us on that.
Personally, I think like we could have used more training, more practice. But maybe like something to calm my nerves. So yeah, I have to say, okay, that was not our best performance. But I do agree, giving more practice, especially since not all the members in the team are necessarily qualified or have gotten the training for like, you know, the basics of CPR, that sort of thing. I think that's important. But I do feel this is vital for every healthcare practitioner or anyone in the medical field to do something like this, to, you know, learn to be calm in a recess, yeah.
Okay, you covered most of the things. I would just say you should also provide a spacious area so that we don't get congested, and yeah, that's what I would say.
So I picked up on two things. The one thing I want to ask the audience is, whom here have performed a resuscitation or participated in a resuscitation? Okay. Keep your hand raised if you knew every one of your team member that was with you in the resus. So with the exception of a theatre nurse, which is a closely knit team working together, none of you have been involved in a resuscitation where you know anyone. So on that point, I hear that you want more time to practice your skills, and that certainly is something that we can do. But I think equally important is your communication skills and the value of teamwork. And I think as part of the Skills Lab's vision, taking the faculty simulation forward, that is certainly something that we need to look at. But in the same breath, I want to say that I'm so proud that we are breaking down the silos. So I expect each of you, when you go back to your clinical platform, if there's a resuscitation, engage in it. You don't need to know anyone there. Engage in it. If you know good quality CPR, early defibrillation, you can do a resuscitation. All right. Any other team member from the captured peoples? Okay, how about the angels there in the back?
Hi. Yes.
And the devil.
No, it was a very good experience. It is quite stressful, so to be able to practice this and go through it was very helpful. And you actually understand how the communication helps a lot to say, okay, I've done this, and it's nice to do it and then see the next time what you can improve on as well.
Anyone else from your team?
Yeah, hi everyone. I think the biggest thing is just to stay calm and just to think, because all of us, I'm pretty sure 90% of us know all of the theory. Well, not all of the theory. Well, the basic theory, like your primary survey, etc. But to be able to just go through that when you're in a recess, your adrenaline's pumping, you're breathing fast, you're not thinking straight. I think that's one of the biggest things. Just stopping and thinking and staying calm is, yeah.
Before we move on to the next team, I want to ask whom of the students here participated in last year's SimUPWars? I would also like to hear from you guys. Was it better the second time round or was it worse?
I think for me, it was better because you kind of become a bit more calm as you practice the skill more often. So you're able to think a bit more rationally. And I experienced that with myself that when, if it's not your first one, then you're a bit more level-headed and you can assist your team leaders into thinking clearly where maybe they are not seeing some of those points.
Thank you. There's one team that we didn't hear from. Team 4.
Firstly, from our team, we'd really like to thank you guys for setting this up. What we notice is that it sort of fills the gap that we're missing as undergrads. And we don't really get this experience if you go and rotate in the hospital. So this is really great. Thank you very much. And also, I think for me as the team leader, there were moments where I was like very flustered and I didn't really know what to do, but I could rely on my team's knowledge of like what their roles were and what other people's roles are. So I think it's important to not just solely focus on your role. So if you're only doing H's and T's, don't only focus on H's and T's, but also know the role of the drugs individual or how to do the compressions. So we were able to then, if we had to, we would have been able to alternate roles if it led to that. But also it's very stressful to be there and there's like people watching you, and yeah, there was just a lot going on, but I'm glad that we were still able to remain fairly calm, and we're definitely going to do it next year as the same team.
Yeah, I think a good starting point is for this year's team leaders to maybe draw up a roster. Then we can take the dummy into HW Snyman Foyer and you can get to practice there once every month with the dummy for the whole day.
I think we need a lot more scary dummies because in BCMP, I do see a lot of dummies because we're more practical, but those dummies are cute and everything. This one was just, yeah, it looked scary. So I think we need to see more of the scary dummies.
Point taken. Yes, the Skills Lab will do a moulage course with Mr. Rod Campbell from Survival Technology in next year. Anyone else? Caleb?
No.
Sean, then Caleb.
Okay. So I had some of my colleagues look at me and go, wow. I'm talking to the devils and the angels. I mean, the angels and the devils is that they asked for a consult. And my answer straight back to you was, I only nail something that is alive. I've had that experience. And hence I replied it like that. And I want to take my hat off to you for going straight into it. You looked at me like with this face like, I'm looking for help, but you're not giving it to me. But you stood your ground and you continued to do what was appropriate. So well done. And I encourage the panelists here. That's not what we do. That's not how we try and give as much as we can over the telephone, even though it's not our forte or our speciality. Yes, that would have been a speciality for an orthopod, but there was a lot of other things that were happening there. So try and give as much input as we can. So well done in terms of that. So congratulations.
Caleb?
I just wanted to say that I said it to the previous group, but standing up and doing a sim in front of everyone is awesome, and it's very brave, and I'm really, really chuffed that you guys are keen to do those kinds of things. Just on the panic stations, you need to remember it's not your emergency. You are outside of the emergency. You're bringing calm to the emergency, and as soon as you take yourself out of it, take a few breaths and bring yourself back to baseline. The other important thing is once the patient's in arrest, you cannot make them worse. So take a deep breath, chill out, follow the algorithm, and it will work, or it won't work, but it won't be, you physically cannot make them more dead. They are dead already. So just do all the things that you can, and as clearly as you can, follow the algorithm.
Very good advice. Someone from the audience? I just want to remind you, if there's anyone that would like to debrief with one of the psychologists on campus, please feel free to make contact with the Skills Lab staff so that we can arrange such for you. Even if it relates to the snakes outside. I know Mrs. De Pree said she's going to see someone after seeing the snakes. Anyone else want to share something? Yes, sure.
Guys, another one. When you're switching compressors, it takes you a little bit longer than 5 seconds, and I'm worried about that. At least when you know whose second compressor, then they must be ready. Want them 10 seconds ahead of time to say, you're about to come in, are you ready? So that we don't waste time while switching. Remember, we are buying time. We need to buy time for this patient to get better. So let's try by all means to minimize interruptions and minimize everything. And the last group, it took you more than 10 seconds to actually get onto the patient. And that's too long. Let's us please remember that we're buying time. Let's buy enough time for the patients to survive. Thank you.
Perfect. So we're going to take a comfort break now. Good morning, Dr. Grobler. Your mentor is here. We're going to take a comfort break now. Can we please start at exactly 11:20? Thank you so much. The VIPs can join us for tea and something to eat at the same place. Students, you're welcome to visit CRISP. VIPs can join us for tea and something to eat at the same place. Students, you're welcome to visit CRISP.
everyone? Hello? Are we ready to start?
Okay, ladies and gentlemen, before we start, I would just like to remind you that MPRET has their textbooks out for sale outside, 300 Rand a book. And then the snake bite, I forget the whole name. They also have flipper cards for both lay and emergency care providers to treat snake bites in South Africa. Then I'd like to welcome David Stanton from Netcare Millpark. He's the hospital manager there. So thanks so much for joining us, Dave, as well as his wife, Dr. Tammy Bailey Stanton. I'll introduce them formally a little bit later on. Then also Prof. Werner Cordier and Prof. Natalie Shellock, our resident pharmacologists, and Professor Morten Brandt there in the back, one of our surgeons, and Prof. Dries Engelbrecht is here as well. So for the next teams, there's a lot of experts available that they can raise their questions to. That said, let's get started. Is everyone ready? Simman, Wanda, all the judges ready? Perfect, thank you.
Thank you. Right, they're getting ready. All right. You can go in. Yeah, you can stand here. Stand here. Hi, Bobby. Hi, Bobby. Hi, okay, it's our Bobby group, ladies and gentlemen. Welcome. And then team leader, please introduce your team members.
Hello everyone, we are Team 7 and we are called Resource Barbies. I am Fatima and I'm a 4th year medical student. This is Nzaka, also a 4th year medical student. This is Izan, a 1st year sports science student. Mary Jane, who is a 3rd year nursing student. Lebo, who is a 1st year BCMP student. And we have Apile, a 2nd year medical student.
Still morning. Good morning, team. I'm Wanda from the Skills Lab. I'm going to prep you for your patient. Okay. Your patient is a 34-year-old male that was brought into the emergency room by EMS. He was in a motor vehicle accident. It was a high-velocity accident, and he was an unrestrained driver. He was extricated from the car, but sustained a traumatic amputation of his right leg, which currently has a poorly applied pressure bandage. He also has some bruising and bleeding over the right temporal area and a decreased level of consciousness. According to another passenger in the vehicle, he doesn't have any other medical history or any medication that he's taking. Please go ahead and help your patient.
Okay, thank you. Team, let's get ready. Okay, cool. H's and T's, please control bleeding immediately. Direct pressure. Please connect the monitor. Level. Please get oxygen on the patient. Timekeeper, you've recorded everything that we need to know. Okay. Let's remove anything and apply direct pressure. Can we apply a tourniquet as well, please? Okay. Pack the wound extremely well. We're assessing the pulse.
BP applied. Can I please have SpO2?
Okay. We've got a pulse, heart rate of 140.
Okay, it's crashing.
There's no press. Patient's respiratory rate is 28. We've got a non-rebreather. Mask 8 liters per minute. Running. Can I insert 2 large bore IV lines, please? Can I get a blood gas?
Okay.
Got a good pulse. Saturation. Okay. Can you prepare BVM as well?
Blood gas taken and blood ordered.
Okay. So can we give 20 ml per kg fluid? 500 Please assess the bleeding there. Can we have a GCS on the patient currently? Eyes open.
The GCS is 10 out of 15.
Okay. Can you put gauze? Airway open, clear, maintained?
For now, yes.
Okay. So airway is clear, open, maintained. Breathing, equal chest rise, unrestrained. Any bruising to the chest?
You're welcome to listen.
Okay. Any bruising to the chest that I see?
No.
No bruising. Okay.
Okay, H's and T's. The patient has hypovolemia. 1 second. Lebo, you need anything?
Okay. Start CPR. Check for pulse. 2. Okay, no pulse. Start CPR. Please insert an OP airway, BVM. Connect the monitor. Timekeeper, please start. Time for CPR.
13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Can we please help?
Okay. You got it?
Okay. 5, down, please. 7, what's not connected? 9, 10, 11, 12, 13, 14, 15,
Keep going.
16, 17, 18,
Good.
19,
Chest compressions.
20,
Can we get an eye gel there?
22, 23, 24, 25, 26, 27, 28, 29, 30. One minute left. 1, 2, 3, 4, 5, 6, 7,
Stick nicely,
8,
Nzaka.
9,
Go,
10,
go.
11,
Listen to your
12,
metronome.
14, 15, 16, 17, 18, 19, 20.
Okay, eye gel
21,
inserted,
22,
timekeeper.
23, 24, 25, 26, 27.
Lebo, you're doing well.
29,
1 every 6
30.
seconds.
Okay, please hear the patient.
Okay.
Checking.
30 seconds.
Okay. Analyzing.
Mama, which monitor are we looking at? Our monitor or the screen?
Which one?
Our monitor, okay.
Okay,
So it's
continue compressions.
is it connected nicely on the side?
15 seconds. Five, 4, 3, 2, 1. Reset.
Swap, swap,
Okay,
swap.
continue
Okay, H's and
compressions,
T's, how are we
no
doing?
pulse out.
Okay, patient has hypovolemia. Patient.
5, 6, 7.
Okay, wait guys.
Okay,
Is the pad applied?
saturation. Continue. Zero saturation, so the patient
Is it connected?
hypoxic. The line.
The pads.
Yes, connected.
Check the other pad.
Is it still not showing connected, guys? No, no, look at the monitor. See if in the side if it's connected. Still says apply pads. Into the monitor, is it connected? In the side? No, no, in the connection. In the connection on the side.
Can you please give help, please?
Is it, are we not connected properly?
Seems like your defib is broken, so,
So
let's
can you
switch.
swap over to an AD? Okay, continue CPR, you're doing well. Apila, are you good there?
50
Okay.
seconds.
Can we drop adrenaline also, please?
Adrenaline 1 milligram drawn and pushed.
Okay. That's 2 cycles of CPR, right? Apply quickly, 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 quickly. Quickly, Nzaka. Quick, 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 quick.
You want H's and T's?
Yes, H's and T's, please, let's go. So hypovolemia.
Yes, and patient patient is hypoxic.
So we've got
That's
fluid
low
running.
saturation. Yes.
We've got oxygen going. We've got the tourniquet to control bleeding. Is there still bleeding from the site?
There was
Is this?
10 seconds.
The bleeding is reducing.
Okay.
5.
Okay. Analyze rhythm. Switch it on.
2.
On. 1. Please move away from the patient.
Okay. Continue CPR.
Continue CPR. Okay, charging. Okay. Okay, move up. Okay.
No.
I'm here, you're here, everyone is here. Shock administered, continue CPR.
Okay, let's go. Okay. So our blood gas, do we have any reversible? Can we read it?
Blood
The machine is offline.
So we know that the patient is already using some nutrients. We have the fluid running.
What else?
The patient can be potentially hypokalemia.
Okay. We don't have a blood gas for that currently. Okay, time? 1:50.
T's tension pneumothorax. Is good. Just
Can we have do we have an ultrasound available?
The tech is on vacation.
Okay. That's good.
Chest rise and compression. Okay, cool.
Then trauma, we already he had a car accident. He does have a left bruise on the right side.
Ma'am, can we look at the monitor? Okay, so is that the monitor we refer to now? Okay, cool. Pulse check, please. Pulse check in Taco.
Okay, still no pulse valve.
Wait,
Continue.
is that no pulse? Just wait 1 second, guys. Okay, we have a pulse. Okay, so let's continue with ventilation for now. Right. Okay, carry on giving fluids. We need to control. How's the bleeding now, ma'am?
It's better.
Okay, cool. If needed, we're gonna administer TXA to control bleeding, anti-hemostatic agents. Can we repack this if needed? Can we get a blood pressure and a full set of vital signs, please? Put the blood pressure cuff.
Pressure cuff is already on.
Okay, it's cycling. Okay, so 76/40. How much of fluid have we run in already?
Not sure.
Do we have our bilateral IV lines up? Okay, cool.
There's only one. There's unilateral.
Where's the?
Would you like me to
Let's
put
put the
up another?
bilateral IV lines, I guess. Okay, and can we order blood? Or negative, please? There's the fluids at the bottom. No, Ringer's lactate, please. Can I put bilateral lines, please? Hang it up there, Zaka. Okay. Are you doing well there, Lebo? Is there any resistance to bagging?
No.
Nothing at the moment. Okay. Do we have an end-tidal CO2 probe?
Out of order.
Okay. Saturation is 93%. We're doing well. Heart rate, pulse. Okay. So we've got the fluid free flow running. Can we insert another one?
Yes, we have another one here.
Can I hang it up, please? Can we order O negative blood?
Okay. The patient's temperature.
There's no temp. Can you touch the temperature probe, please? Add a bear hugger to keep the patient warm.
Here's the bear hugger.
Okay, we've administered fluid, 500 moles. Any change in blood pressure? Can we recycle the blood pressure, guys?
The blood pressure should go up.
We're just waiting for blood pressure just to see if we need inotromic support or more fluid. Okay, so we're going to prepare for intubation. We need a definitive airway. Any secretions, vomiting?
I'm going to stop you there, guys. Well done. Okay. Your patient has a pulse, okay? So you can leave everything just like that for me.
Tasting.
Judges, if I can have your attention, I'm going to cycle the notes of this team. It's impressive. Okay. Irisa's notes from the Barbie team.
Right, ladies and gentlemen, I present to you Heartbeat Heroes. Woohoo! Kindly introduce your team.
Hello everyone, we are the Heartbeat Euros. All right, so my name is Marcel. I'm a fifth year medical student. I'm going to be team leader today. Then here on my right, firstly, we have Amara. She is going to be on our airway. She is a second year sports science student. Then next to her here, we have Ntombi. She's going to be in charge of HS&Ts and helping out in the beginning with drugs as well. She is a third year nursing student. Woo! Then next to her, we have Yana. Yana's our second year medical student. She's going to be in charge of timekeeping and being our scribe today. Thank you, Yana. And then next to we have Nicola. Nicola is our fourth year medical student. She's in charge of drugs and defib. And then at the end, we have a boss man here. We have Jason. He is first year sports science and he is in control of circulation today.
Thank you.
Afternoon, are we all afternoon? Everyone, I'm Wanda. So if you don't know me, I'm from the Skills Lab. Welcome. Okay, so I'm going to prep you on your patient. Listen up. Your patient is a 34-year-old male that was brought into the emergency room by EMS with a history of being involved in a motor vehicle accident. It was a high-velocity accident and he was an unrestrained driver. He was extricated from the car but sustained a traumatic amputation to his right leg. On that leg, he has a poorly applied pressure bandage. He has bruising and bleeding over the right side temporal region and decreased level of consciousness. According to another passenger in the vehicle, he doesn't have any other medical history or medicine that he's taking. Please go ahead and help your patient. Thank you.
Thank you very much. Okay. I'm going to put on my PPE first. I'm going to arrive at the scene, check for any hazards. There's no hazards now. Sir, hello sir, are you awake? Hello sir. Okay, can I please get my resusc team in? Please put your PPE on, team. Move to the patient's feet. Okay, the patient is not breathing well. I'm going to check for pulse and breathing simultaneously. Okay, the patient does have a pulse. He's not breathing well. Can you please start rescue breaths? Thank you, team. Please use the oropharyngeal airway. Just wait for CPR. Just quickly check the pulse. There's a pulse. Don't start with CPR yet. Thank you, Yana, for keeping time and taking long. There we go. Mask giving. Please use the oropharyngeal airway as well. Thank you very much. Please analyze the chest for us, Nicola. There we go. Jason, please, circulation. Will you please apply this pressure bandage tighter and just apply bandage? Do we have a tourniquet on the trolley? Knock a shoulder. Okay, don't shock for now, please. Please continue with rescue breaths. Please, one every 6 seconds, please. Tighten it. We have a tourniquet. Please apply the tourniquet for us, Jason. Thank you very much. Okay. As soon as the tourniquet is applied, just verbalize, please, to Yana. Thank you very much. There we go. Please continue with the rescue breaths there. Can you please get the monitors on for us, Nicola? Appreciate that. Thank you very much. Please can you please some 2 IV lines up for us as well. There 2 large bore IV lines in Tombi, please. Please will take some bloods as well for us and type and screen as well. Can you please activate a massive transfusion protocol for us in Tombi as well?
2 IV lines inserted on both hands, taking arterial blood gas, taking gas for laboratory testing.
Thank you very much. Tourniquet is also applied, Yana. Thank you very much. Can you please start those rescue breaths for us in Tombi? Thank you so much. Amora, thank you so much. Thanks, breathing once every 6 seconds. Thank you very much. How are the patient's vitals looking at this point? Okay, we have the leads are on. Thank you very much. We'll get a reading just now. Okay, patient is tachycardic. Do we have his blood pressure is low? Okay, can you please get fluids in? Thank you very much. While we wait for the blood to go. Thank you very much. Okay, that's all good. Can we just apply the pads quickly? Thank you very much. Jasmine, will you just check for us when the bloods arrive so we can give blood to the patients as soon as possible? Thank you very much. There we go. Thank you, team. Doing well.
What should I do myself?
I think for now, please just palpate the patient's pulses for us. Please check radial pulse, check the carotid pulse as well for us, and check his femoral pulse. The bleeding has stopped on the leg. We were happy with that. Thank you very much. There we go.
I don't feel pulse.
Not feeling any pulse. Check carotid pulse as well, please. There we go. Okay, patient is still tachycardic. There we go. It's not a shockable rhythm. All right. Not feeling any pulse.
Yeah.
Okay. Nicola also says the pulse, and if there's no pulse, please start with CPR. No pulse. Please start CPR, Jason, immediately. Thank you very much. Please really start the momentum for us as well there, Yana, just so you get the depth of the CPR. A bit faster, please, Jason. Thank you very much. Good CPR. Keep the rescue breaths up. Please switch to LMA as soon as possible, Amara. Thank you very much. There we go. There we go. Thank you, team. Looking good. Good compressions there, Jason. Okay. Zombie, I think we want to start with the H's and T's as soon as we get a gap here. As soon as we get a gap to analyze the rhythm, can we please get the sonar ready so we can have a look at the chest and the heart and the abdomen? All right. Thank you very much. Can you please also give us 1 amp of cyclocapron as well, Zombie, please?
1 amp of cyclocapron prepared.
Thank you very much. Can you please push it for us, Ivy? Thank you. Sorry, rates are dropping. Okay. Can you please put an LMA for us in? Move the defender to airway.
Ideal given.
Thank you. There we go. Move to the iGel for us. Thank you very much. Please drop the bed as well a little bit fast so we can just get some better chest compressions there. Sharp. We can just help drop the bed, please.
Igel's inserted.
Thank you very much. There we go. So need the CPRs. Please keep the 2-minute timer for us up, Jana, please. There we go. You happy with good compressions, Jason? Thank you very much. Looks good. There we go. Have the bloods arrived yet?
The machine is broken.
The machine is broken. Okay. Do we have arterial blood gas results?
Blood gas offline.
Blood gas offline. Okay, 100%. 15 seconds. Okay. Please count. Okay, so.
9.
All right.
8, 7, 6.
All right.
5, 4, 3, 2, 1.
Okay, stop, swap, please analyze the rhythm for us, please, team. No pulse. Analyze the rhythm for us as well. Is there a shockable rhythm? Yes, we have a shockable rhythm.
Okay, charging.
Charging.
Clear.
Everyone clear. Make sure everyone's clear. There we go. Thank you very much. Continue CPR, please, for Samara. Thank you very much. Jason, continue those rescue breaths 1 every 6 seconds. Thank you very much. Thank you, Jana, for keeping time. And Zombie, can you please get us 1 milligram of adrenaline and with flush, please?
1 milligram of adrenaline with flush prepared.
Thank you very much. Nicola, would you please just feel for a pulse as well again? No pulse. Okay, thank you very much. Just continue CPR. Just get a bit more depth there for us, Samara. Thank you very much. Allowing some good chest recoil. Thank you very much. Jana, will you just let me know as soon as our time has lapsed for adrenaline, please? Thank you very much. There you go. Keep up those chest compressions, Samara. Thank you very much. Just keep those rescue breaths going, Jason. The patient's BP is still low. Can you please hang us another? You have the bloods have arrived. Thank you. Please hang the bloods for us. The blood's going. Thank you very much. That's great. There we go. The compressions keep going. Yeah, the lines are up. Thank you. The blood gas machine is broken at least. Thank you for the lines up there. 100%. Thank you very much, team. You guys are doing well. How long before our next pulse check? 30 seconds. Right. And Tommy, 30 seconds. Please get the ultrasound ready for us that we can have a check in the gap to just have a look at the heart and the chest.
Ultrasound ready.
All right. Thank you very much. All right. Will you just count us down when we get to 10 seconds, Jana? Thank you very much. All right. Thank you, Amara. Keep it up. Good to see. Thank you, Jason. All right. There we go. How long do we have left now?
10.
All right. Thank you.
9, 8, 7.
Hold on, team.
6, 5.
Okay.
4, 3.
Just get ready for the ultrasound, please.
1.
Okay. Stop. Swap, please. Analyze. Please do sonar of the heart.
Doing the sonar of the heart is a very weak
The sonar
Weak
is
pulse.
broken.
Okay. Sonar is broken. Okay. You can stop the sonar. Please do the HSC from head. Stop with CPR for now. We have a pulse. Okay, please push for us another 1 milligram of adrenaline stat with flash, please. Continue rescue breaths 1 every 6 seconds. Thank you very much. There's a weak pulse. We have a shockable rhythm. Can you please charge the paddles for a shock? Okay, everyone please clear. Oxygen off. Thank you very much. Right, are you ready? I just a normal shockable rhythm, yes. Thank you, Nicola. Here we go, is it charging? The pads on.
No, it's not connecting very well.
Okay, everyone just quickly clear the chest to analyze. Let's switch to paddles, please. Yeah, switch to paddle. Please continue rescue breaths. Right, let's quickly put the
You can see CPR.
knobs back on. Do you have the circles for us just to put them back on? Thank you very much. I'll put them on for you. Put them on. There we go. Thank you very much.
Joe Cuban.
Thank you very much. There we go. Okay, analyze a rhythm for us, please. Just continue rescue breaths. You have a shock ball rhythm, please charge.
Charging. Wait. Oxygen clear.
Everyone clear, oxygen.
I'm clear. I'm clear. Thank you, shock delivered. Thank you very much. Continue CPR, please, fast, Jason. Thank you very much. Can you please get another? Can you get us 300 milligrams of amiodarone, please? That we can push next.
300 milligrams of amiodarone given.
All right, thank you very much. And Tommy, will you start we want to start with the H's and T's with me, please, quickly. Will you quickly start with the head, with the head? Let's check out his head trauma.
I'm going to check the head, and I see that there is a right temporal fracture.
Okay. So is the patient actively bleeding from the fracture?
A little bit.
Okay. Can we just get a bit of compression bandage on that as well, if we have? Otherwise, fine. Can you please have a look at the patient's pupils for us as well, Tommy? Oxygen picking up. Thank you very much, team. It's going. That's good. Okay. Okay. Nice. Good. Well done, team. How long before our next 2-minute pulse check? A minute. Okay. Okay. See, we have a sinus rhythm team, so just be aware when we stop now. Let me just keep those rescue breaths going. Thank you very much. The pulse oxygen is picking up. Nice, team. BP is picking up. Good to see that. Right. I think we just want to rule out a last H's and T's. The blood gas is out, but the patient doesn't have any toxins. Trauma is ruled out. We can't comment on the hyperkalemia. Patient's warm extremities to touch. Okay, patient. Okay, please stop CPR because the patient is responsive. Continue those rescue breaths. There we go. Right, team. Thank you. Let's start with our secondary survey. We mentioned from the scene the patient was in high velocity vehicle accident, no allergies, no medication the patient is taking. On general appearance of the patient, you can see the patient is still in pain, is struggling, is still unresponsive at this point in time, but we have a good heart rate, it's a bit high still at this moment. Saturation is good, BP is still a bit low. Can we please hang another liter of blood? I think that's finished now.
We're going to stop you there.
Okay.
Thank you very much. Well done, guys.
Ladies and gentlemen, I just want to take this opportunity. Zanique from Louis Clute Productions just informed me that we have 5 guests from the United States of America that are currently watching. So unfortunately, due to the POPI Act in South Africa, we can't identify them. But we say welcome from the States and thank you so much for watching. Looking forward to your feedback.
Right, ladies and gentlemen, Code Blue crew.
Good day, everyone. So I'm the team leader. My name's Roach. I'm fifth year medicine. This is Charlize. She's on H's and T's. She's also fifth year medicine. Then we've got Daniela. She's first year sports sciences. Yes, she's our scribe. Then we've got Nomfundo, sorry. Nomfundo, she's a second year BCMP. She's our DFIP and drugs. Estian, fourth year medicine, is on circulation. And Lebo, our airway and breathing, she's our second year medicine student.
Welcome, guys. Just have a quick listen. I can see you're very excited to start. Okay, I'm Wanda from the Skills Lab. I'm going to prep you on your patient. Your patient is a 34-year-old male that was brought into the emergency room by EMS with a history of being involved in a motor vehicle accident. It was a high-velocity accident, and he was an unrestrained driver. He was extricated from the car, but sustained a traumatic amputation of his right leg, which has a poorly applied pressure bandage. He also has bruising and bleeding over the right temporal region and a decreased level of consciousness. According to another passenger in the vehicle, he doesn't have any other medical history and not taking any other medicine at the moment. Go ahead and help your patient. Thank you.
Okay, can I get my resus team? We've donned our PPE. Okay, can I get a security C-span for me, please? Check the pulse.
No pulse.
Okay, but you can hear. You sure?
Patient is conscious.
Okay. Start.
I can feel pulse.
Okay. Is the airway, is the nasal canal of the breathing connected? Great. Okay. I don't have any vitals. Can I get a monitor, a blood gas, and 2 IV lines, please? What's his breathing? Okay, I still got no. Okay, because I'm Nomfundo. Nomfundo. Can I get the ECG, the electrodes on, please? The electrodes. Yes. Okay, there's a PP. Remember the SATs as well, Charlize. Label. Can you please pass the SATs to Esther so that we can just put it on, please? The SATs, yes. Thank you. Okay, we've got a VT. Check the pulse. No pulse. Okay, start compressions. Lower the bed at the back, please.
1, 2, 3.
Estian, lower the bed at the back. There we go.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13,
Okay.
14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Okay, feel pulse. Make sure you feel pulse because we're picking up pulse on the electrodes.
1, 2, 3, 4, 5, 6,
No pulse
7,
palpable.
8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22,
Okay.
23, 24, 25.
Incident advanced airways hypnotic device. Okay, see if you can get something on there. Estian, hold.
5, 6.
We're not picking. Okay, make sure there's good contact, please.
9, 10,
Okay.
11, 12, 13, 14, 15, 16.
We need to. Do we have blood gas results yet?
Oxygen, please. Machine is broken.
Good. Nothing new. Okay, check the pulse, please. Estian, keep counting. There we go.
No pulse.
10, 11, 12.
Make sure you feel for the pulse.
16, 18, 19, 20, 22, 23, 24, 25, 26, 28, 29, 30.
2 breaths.
Okay, let's get the pads on, please.
1,
30
2,
seconds.
3, 4, 5, 6,
There isn't
7,
one, okay.
8, 9, 10, 11, 13, 14, 15, 16, 17,
We've got to be
20
19,
seconds.
20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Deep breath.
1,
10,
2,
9,
3, 4, 5,
8,
6,
7, 6, 5, 4,
1 Mississippi,
3,
Mississippi, 3
2,
Mississippi, 4
swap.
Mississippi.
Stop, swap, and analyze.
1 Mississippi, 2 Mississippi, 3
Do we trust
5
the ECG or? Okay, it's a shockable rhythm.
1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi,
Charging.
I don't know which one to trust, but
1 Mississippi, 2 Mississippi, 3 Mississippi,
check the left pad,
5 Mississippi.
the right pad.
1 Mississippi, 2 Mississippi, 3 Mississippi, 4
Okay.
Mississippi, 5 Mississippi. 1 Mississippi, 2 Mississippi.
Okay, can we get a decent
2
20K?
Mississippi, 4 Mississippi, 5 Mississippi. 1 Mississippi, 2 Mississippi, 3
Charlize?
Mississippi, 4 Mississippi.
It's okay, it's fine.
1 Mississippi, 2 Mississippi, 3 Mississippi,
Um,
4 Mississippi, 5 Mississippi.
Still no blood gas. Can
1 Mississippi.
Charlize, can we get cyclocapron, please?
4 Mississippi, 5 Mississippi. 1 Mississippi, 2 Mississippi, 3
1 minute.
Mississippi, 4 Mississippi, 5 Mississippi. 1 Mississippi, 2
Cyclocapron
Mississippi,
administered.
3 Mississippi, 4 Mississippi, 5 Mississippi.
Analyzing heart rhythm.
1 Mississippi, 2 Mississippi, 3 Mississippi, 4
Hands
Mississippi.
off the
Okay,
patient.
hands off the patient.
Shock advised.
Okay.
Charging. Stay clear of patient.
Okay.
Deliver shock now. Press shock delivered.
Okay, continue CPR.
1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi.
Okay, stop. Feel for a pulse.
1 Mississippi, 2 Mississippi, 3 Mississippi.
Okay, stop.
4
Label.
Mississippi.
Sure.
1
Okay.
Mississippi, 2 Mississippi, 3 Mississippi, 4
Charlize.
Mississippi, 5 Mississippi.
C-spine. Thanks.
1 Mississippi, 2 Mississippi,
The
3 Mississippi.
machine's still broken, or have we
5
used the other blood gas machine?
1 Mississippi.
Can I use an expert, please?
Dr. van der Merwe or anyone else? Prof. Engelbrecht? Prof. Engelbrecht, let's give him a chance.
What's next? We've don't have a pulse yet. We've secured a C-spine. We've administered cyclocapron. We've applied a faster tighter tourniquet on the amputee. What would you advise next?
1 minute.
So you've done very well so far. I think at your next cycle you can check for a pulse. But I think it's very important in trauma to always consider the major causes of cardiac arrest in a traumatic patient.
Yes.
So you can do bilateral finger thoracostomies to rule out bilateral tension in the thoraces. You can sort out the airway to rule out airway obstruction, so you can intubate the patient if you haven't intubated the patient. It's
Okay.
appropriate in trauma, not in normal CPR.
30 seconds.
Just check the pulse first. And then you can address your hypervolemia with blood products.
Yes.
And you've given cyclocapron. You can add calcium for your hemostatic cardiac arrest.
Okay, cool. So HSNT,
10 seconds.
will you add blood products, please? 1 to 1 to 1. Where are we at now? Turn down.
He's got 10 seconds.
6, 4.
8, 7, 6, 5, 4, 3, 2, 1. Swap.
Okay, stop and analyze. Feel for a pulse, please.
Blood products administered.
Stay clear of patient.
Okay, shock is advised by the AED.
Analyzing heart rhythm. No shock advised.
Okay, feel for the pulse.
If needed,
Okay, Charlize, you can just put that down, it's fine. Calcium,
No power, Mississippi, 2
Still no pulse.
Mississippi, 3 Mississippi, 4
some cardio vision.
Mississippi, 5
Okay, everyone, we're going to stop it. Thank you very much. Well done. Your patient has a pulse.
Guys, I just checked the live feed and I wanted to read you some of the comments. It's very funny. So I remember one of the teams said that they require or they requested a bigger space to do the resuscitation. So Bernard said, spacious area, come do a resus on the road. Similarly, I can say do it in a heli. And then for Barbie Girls, Anonymous 15119 says, please be my doctor. I also want to welcome Prof. Sumaya Adam in the audience. She's just joined us. She's from obstetrics and gynecology. Next to her is Dr. Yvette Klope from the basic medical sciences. Then Karine Basson, a flight nurse from Air Rescue Africa, just joined us together with Patrick. Patrick from the rocket team. And I'm just going to have a look, see around if I missed anyone that joined late. Okay, so we are up for team. Where's Vian? Where are we now? Team 9 or 10? Okay, final team coming in now. Then we'll do a debrief. So experts, judges in the audience, please keep your notes by so that you can give the students some good feedback.
Ladies and gentlemen, our very, very last group, we have Resus Angels.
Good afternoon, everyone. So we're the Resus Angels, your last and final spectacle. My name is Bryce Swenson, and I'm a final year medical student.
Hi, everyone. My name is Lerato. I'm a second year medical student.
Hi everybody, I'm Kanyisa Mate and I'm a first year medical student.
Hi everybody, my name is Rorisang and I'm a second year PCMP student.
Hello everyone, my name is Violet Mbongwe. I'm a third year nursing student.
Hi everyone, I'm Valdu and I'm a first year sports science student.
Thank you.
Good
Good day, everyone. I'm Vanda, and I'm from the Skills Lab, if you haven't seen me. I'm going to prep you for your patient. Okay, so your patient is a 34-year-old male that was brought into the emergency room by EMS with a history of being involved in a motor vehicle accident. It was a high-velocity accident, and he was the unrestrained driver. He was extricated from the car, but sustained a traumatic amputation of his right leg, which is covered with a poorly applied pressure bandage. He also has bruising and some bleeding over the right temporal area and a decreased level of consciousness. According to another passenger in the vehicle, the patient has no other medical history and is currently not taking any medication. Go ahead and help your patient. Thank you.
Okay, guys, so we've got a recess coming in. We need everyone to get their PPE on. The first thing we're going to have to do is stop the bleeding from his leg. Okay, while I'm doing that, can you guys please get some monitors on for us? I'm just going to grab the tourniquet here. Okay, so we've got our gloves on. Okay, so we're just going to help you. Just relax for me, please. We're just going to put some monitors on, guys. Okay. Sir, can you hear me? Okay, guys, do we have a response? Please check for a pulse for me.
Sir?
Do we have a pulse?
No pulse.
No pulse. Start CPR for me, please. Okay, guys, can we get a BVM, please? Can I get a definitive airway in the meantime?
Conscious?
Is he conscious?
Yes.
Okay. Okay, so guys, we need to get the bed down. We need to stabilize his head. Does someone have head blocks for me? Okay, we have ECG leads on. Do we have a blood pressure, please? Can we have our pulse ox? Is our pulse ox on? Okay, we've got our patient in head blocks. Pulse ox is on. Perfect. Can I have a temperature probe as well, please? And then can we just get our resus equipment? Okay, can we? Okay, is there no pulse? We've still got. Okay, guys. There is a pulse. Okay, so we've got what does his airway look like? Do we have any teeth in his airway? Nothing there. Okay, is he breathing? Can we have a listen to his chest quickly? Hey guys, I have a reduced air entry on the left lower lobe. Okay guys, we've lost the ECG. Do we have a pulse? No pulse. Start CPR, please. Please start our timer. Okay, can I have a mask? Okay guys, can we get the defib ready? We've got a shockable rhythm here with no pulse. Okay, on the airway, can I please have an end-tidal CO2 monitor? Okay guys, remember our rhythm. 1, 2, 3, 4, 5, 6, 7, 8. Okay, bags on. Can you count out loud for me, please? Okay, can I have a definitive airway as soon as possible? Pause CPR for a rhythm check. Okay, we've got a ventricular fibrillation. Start CPR, charge the paddles first, please. Okay, are we charging? Okay, come on to defib for me on the machine, please. Turn it to 1 for me. Turn it to 1 for me, please, Violet. To 1 here. Okay. Just continue CPR.
1 minute has elapsed.
Okay, guys, can we charge? Do CPR while we're charging. Okay, clear the patient. Okay, shock delivered. Continue CPR for us. Can I get a definitive airway with an end-tidal CO2 monitor, please? Violet, can I have the mask, please? Okay, can we prepare our first round of drugs? Okay, guys, wait a second. Can we feel for a pulse?
30 seconds.
No pulse, continue CPR. Okay, continuous CPR, please, with 1 breath every 5 seconds. Okay, guys, we have no end-tidal CO2 reading here. Can we check for a pulse, please? Still no pulse. Okay, can we have our first dose of adrenaline? Okay, thank you. Continue compressions. Guys, I still have no end-tidal CO2. Can I have a monitor, please?
Broken.
It's broken. Okay. Okay, can I ask for some help from my experts just with next steps, please?
Any expert who wants to jump in here? Yuan? Dr. Yuan?
Yes, how can I help?
I just need an idea of next steps in my MBA unrestrained patient.
And have you decompressed the chest perhaps?
I haven't decompressed the chest.
So we can look at decompressing the chest, and you've got bilateral lines up giving fluids.
Okay, guys, can I get 2 lines up? Can we take bloods and a blood gas, please? Can you prep for a chest drain for me on the right
Have
side?
you considered pelvic fractures? Maybe
Okay,
extract
guys,
the pelvis as well?
Can we do a head-to-toe examination of our patient, please? Okay, so we know we've got possible lines are up. Do we have bloods? Okay, can we check any? Okay, I'm gonna check for if the pelvis. Okay, is the pelvis opening and closing?
Pelvis is stable.
Pelvis is stable. Okay, we've got our tourniquet on. Can we prepare for a chest drain, please? Can I ask for an e-fast on my patient, please?
The E4 stick is on vacation.
Okay, can we?
10 seconds. 9, 8.
Okay, are we ready for a chest drain? Can we order blood for our patient, please? And you send that blood you took?
1.
Switching.
Okay, we have a pulse back, guys. Can I get repeat vitals?
We're going to stop you there. Thank you, guys. Thank you. Wonderful job. Wonderful job. You can leave everything just like that. Okay, you can have a seat, and you can we're going to do a debrief with you.
Okay, guys, that concludes the first round of our 10 undergraduate teams. Can we please give them another round of applause? You can say, watch my phone whilst you sit there, then you're welcome. Okay. You can hand it to Vian. Okay, so similar to the other rounds, we are going to do a debrief now. Once again, you can either comment on a group individually, or you can give a comment pertaining to all the groups. So let's start off. Who from the judges, experts, would like to say something about team 7, 8, or 9, or 7, 8, and 9? Prof. Dries, I wonder if you can maybe tell us what is the survival rate for traumatic cardiac arrests?
Thank you, all the teams here. No, I think I'm impressed to see how you guys have done. I think a couple of comments from my side, maybe just to point out some academic points about traumatic cardiac arrest. I think what was very good was that I think most of you guys went for the tourniquet. And I think that was something that needed to happen quick. So if you got that tourniquet on quickly and responded to the bleeding quickly, I think that was a very strong point. You know, they're going from ABC to CIBC, and C in trauma is massive hemorrhage. So if there's a massive hemorrhage, you have to address that first. In fact, they found that in trauma, the most common cause of reversible death is stopping the bleeding. I think I like to see hemostatic resuscitation from a lot of the teams, which was very good. In fact, the first group mentioned 20 mils per kg fluid, which is a little bit of an older number. I think they're moving away from it now. Some of the other groups didn't mention an amount of fluid, and I think it's good if you mention an amount of fluid, even if it's not, even if you're going for 20 ml per kg. Actually, in ATLS they're going now for 1 liter in an adult, which is less than 20 ml per kg, because they're trying to move away from big amounts of fluid, because it actually interferes with clotting and so forth. So even if you say 20 ml per kg, which is technically not the right number anymore, I think it's good if you say a number, and that's quite a good point. I saw that the patient went into VFib, which is a bit unexpected. In trauma cases, most patients don't go into VFib arrest. They tend to go into a PEA arrest because it's actually a low flow state. But what can happen is that a patient can have an underlying medical condition like a myocardial problem. This patient's already 34 years old and a male, so that could technically be the reason why the patient went into an accident. So it's unexpected to see a VFib, but it's good that you guys dealt with it and dealt with it with in an appropriate way and so on. I would just want to make 1 or 2 comments about the position of the team leader, and I saw some teams did it well and other teams didn't do it well. The first thing is the team leader must either be at the head or at the feet of the patient, or move from the head to the feet. So the first step is go to the head, assess the patient, open the airway, and start giving instructions to your team leaders. But a lot of team leaders were standing on the side, and that's not actually a good position because you don't have a big overall view of the patient. So go and stand at the feet of the patient, or go and stand at the head of the patient, so that you've got an overall view and take control of your whole resuscitation. So I think that's quite an important thing. What I did miss in all the resuscitations was trauma-specific treatment. So in traumatic cardiac arrest, in 99% of the cases is a hypovolemic state. So you need to address the causes of this low flow state, and that could be something like, you need to give address hypovolemia with fluid and blood products, early administration of blood products. Many of the teams mentioned blood products. And then the second thing is to do bilateral finger thoracostomies. I didn't see any of the teams think of that. I think maybe you were distracted by the specific rhythm that the patient got, but bilateral finger thoracostomies would have been great. So the last team mentioned, and I liked it, eFast. That would be a great asset in a traumatic cardiac arrest, because you can look for tamponade, you can look for maybe lung contusion, you can look for tension pneumothorax, you can look for a lot of things like that. So that would be a great asset, I think. And if you did see that the patient got into this VFib rhythm, I would at the end maybe organize a 12-lead ECG, because that would be maybe a patient that the reason might be something like a STEMI. But okay, it's a lot of things, just the little points that I picked up, but I think the teams did very well, and I congratulate you all. I didn't have specific comments for the specific teams.
Thank you very much, Prof. Dries. That's why he's the head of the emergency department. Any other comments? Then I would love to hear from the teams. It's now your turn. David, thanks so much.
Hi. I only got to see the second half, unfortunately, of the teams. My comment would be around something we call situational awareness, which I'm going to pick on 2 examples. The very first team, the Barbies, there was a moment where they picked up the defib pedals and immediately noticed that they weren't plugged in. Now, while that's a small thing, you'll be amazed the number of people that won't notice that. So noticing the small things, noticing what's not plugged in, noticing what is plugged in, noticing that the monitor is switched to pads and not lead 2. Those are major, major things that make big differences. Everybody can run an algorithm, but the small situational awareness items actually make the much bigger difference. So that was one thing I picked on the first team that they did really, really well. Then later on, there was a team who were trying to diagnose the rhythm and weren't getting a rhythm because the monitor wasn't switched on to leads. And until you do that, you'll never get a rhythm. So those small little attention to detail, being aware about the situation are really, really important.
Thank you very much, Dave. Dr. van der Merwe?
Well, again, thank you very much. It was well done by all the teams. I think they've got good spirit, eh? So they motivated to save a life. I think in general, like the CABC, I think that was probably lacking the most, and that's probably the problem with a mannequin. If you see a real leg spurting out blood, I think everybody would jump for the leg. But obviously the important part is to stop that bleeding. And a few people actually knew how to use that tourniquet. I think for most people, seeing that tourniquet for the first time would be very intimidating. And then the early defibrillation. I think a lot of teams recognized that there was a shockable rhythm, but they didn't always identify the rhythm. And as part of ALS is actually to identify the rhythm, because that will help you treat the underlying cause as well. And sometimes they identified shockable rhythm, but there was still the delay in defibrillation. And likewise, one of the teams actually stopped CPR while there was still a shockable rhythm. So the bottom line is, if the rhythm doesn't change, then you must continue CPR. And then I think what many teams delayed is calling for help. I think as you get more experienced, the one thing you learn is to call for help earlier, because you kind of know where your deficits are. And you can do everything you want for this patient, but you're going to run out of time because the patient's losing blood, and you need the guys with the surgical skills to come and take over. And if you need to evacuate the patient, you need to do that. They need to do that early. And then at the same token, while you're doing it, just do that H's and T's. I think we all get stuck in the same rhythm, and we need to start doing the H's and T's to actually find the causes. The one thing is that, and there's one thing with a mannequin. This mannequin was moaning so out loud when people are doing CPR on it while it was a perfusing rhythm. And I think it's sometimes difficult. You're anxious, you don't feel a pulse. And then the people who organize this simulation, they actually make that mannequin moan harder and harder. But some people are just ignoring it. All we need to get is a mannequin who will take your hands and take them away. So but that's just part of the scenarios that you can't get 100% realistic. But well done to everyone.
Yes, thank you very much. We have a comment here, then with Ingrid, and then I'm going to hand over to the teams.
I just wanted to add that the use of the metronome to monitor the rate of chest compressions was quite a good one that we should all adapt. Maybe adjust the volume a little bit because the resources are chaotic so that we can still communicate and hear each other well. Thank you. Well done.
Well done to all the teams. I just wanted to acknowledge the last team for actually recognizing the patient and addressing the patient. I think that was something to take home.
Yes, that is the communication skills and the teamwork that we were speaking about earlier on, that the Skills Laboratory would like to greatly contribute to speaking about the new curriculums in some of our programs within the faculty. Where's the teams? I would love to hear from the teams. So the mic's coming there to you. Please tell us about your experience and what we can do different next year.
Hello, everyone. So I really enjoyed this experience. I actually really wanted to do it for the first time I heard it, but last year I was excluded because I was in a third year. So I really enjoyed the experience that we had, and I'm so grateful for the opportunity to do this before I even graduate, because now I know I'm like, oh, if I'm in an emergency situation, I remember, okay, no, I did this before with the simulation, I can now do it, and I'm more confident and competent to actually perform it, opposed to if it was my first emergency, I'm like, okay, what do I do? So, and hopefully we can do it again next year. Come back, Barbie 2.0.
Thank you so much. Code Blue.
Yeah, I think we learned a lot, and I think we all see what today is on camera and what we are here, but we've been running simulations in our own head multiple times, and I think that is more like a really important as well. Running a few simulations and communicating between each other. What's more important? What's the next step? And the practice times. I think it was really helpful. Do you have the practice times? I only have a question. Like when we see ECG on the ECG, when we see a pulse. What's more important, the pulse or whether we feel it or not? I think that was our biggest concern, was we couldn't feel the pulse. I was at the feet, so I couldn't feel down there. But if you see a pulse on the vitals, but you don't feel it, well, yeah.
I want you to think about your own question and maybe answer it. What would be the signs of the return of spontaneous circulation?
Would be a heartbeat, like the heart pumping, and I guess the ECG is more sensitive to the...
What else? Where's your team members, before we ask one of the experts? Where's all the students? What are the signs of return of spontaneous circulation? Caleb, do you want to summarize it for them?
So I think what you need to be thinking about is, how does the heart work? The heart starts with some kind of electrical conduction, which translates hopefully into a mechanical contraction, which hopefully translates into some kind of cardiac output. And so what we're trying to find is that cardiac output. If we find the electrical conduction, it doesn't guarantee a mechanical contraction or cardiac output. So what are the things we could use to find the cardiac output? Changes in perfusion, peripheral pulses, a SATS pleth might help you, so the tracing might help you, and your end-tidal CO2. Ultrasound might help you, but it's going to show you contractility, and I guess you could go and see if perfusion is then improved.
Brilliant. Percy, you wanted to say something? And then I'm going to move on to the last team, Team 10.
Guys, all the teams, can you please put just a round of applause for all of you guys? You guys did amazingly well. I realized there's an underutilization of the scribe. Can the scribe maybe move over as a scribe and as a CPR coach? Because you end up looking at the team leader wanting to treat the patient and also looking at, they get flustered, they can't even look at hand placement, they can't follow the rhythm and everything. So if the scribe could also act as a CPR coach so that they look after the mechanics, the smaller things like that, so that the team leader will do what is necessary. Thank you.
Thank you very much. Can we maybe pass up the mic there to Team 10 in the back, please?
Team 8 is also, we can also have the mic.
Oh, great. I don't see you guys.
Yeah, sorry, he's sitting behind here. Awesome. Yeah, we also just want to say we really enjoyed the experience. It was something completely different when you actually get on stage and on set here, when you actually perform, when you get a tachycardia and almost you need a resus. But it was really a great opportunity for us. I think we worked well as a team. We also enjoyed watching the rest of the teams and seeing what they did differently, where we can change and adapt. And well, thank you for all the experts and your advice that sorry we never asked for advice, that we didn't got a little bit too busy, carried away. But thank you for spending your time here with us, and that we can tap your brains as well. We really appreciate it.
Thanks so much.
I think I just want to say well done to my team. I had quite a junior team in terms of qualification, but I think anyone can see that they weren't that junior in terms of enthusiasm and ability. So I just wanted to say I think it was really, having done it last year, having done it this year, it doesn't get less stressful. I think I was less stressed in the last recess I was in Steve. So I think the one thing that we also as students need to learn that doesn't always come through is that we can use aids to help us. We don't always use things, and I could feel myself when I got lost and Johan told me what to do. I could feel Caleb looking at me going, you have the page in your hand, look at it. So I think we need to, as students, also realize that you can use those aids. We're not going to remember everything, so offload your cognitive load onto a piece of paper and look at it. So I think that's something that I need to remember, and maybe something that we need to remind students they're allowed to do. You may not be able to cheat in a test, but in a recess you absolutely can.
Yeah, that's very valuable comment, and I think I keep on referring to Masters of Recess, but the cognitive offloading was also mentioned there quite a couple of times. So that's a very important aspect to remember when you work in an emergency scenario. Anything else? Yes, ma'am. Just check and see if your mic's on.
Am I on now? Okay. I just wanted to say that it was a very nerve-wracking experience. Being in first year, all I know is histology. But I think also having like an amazing team right here really helped me, and like it was an experience of a lifetime. I don't think I'll ever forget this. And I remember during the training, I literally told the doctor that was training us that I've never done CPR before. He's like, don't worry, you'll get it. And like doing this now, I was nervous, but I was able to like listen and see everyone doing what they know, and I was just like, I also will know someday. But it's really an amazing experience, and the exposure is really impactful. And I think, you know, as we continue doing these simulations, even when we have like real life situations, we will know that at least we had like some form of training before. So it was a really wonderful experience. Thank you.
Thank you. I just want to say the University of Stellenbosch just challenged us for next year. So University of Stellenbosch, my name's Runel. Challenge accepted. See you next year. I think Wits is too scared. And I'm only saying that because Johan studied there, so I can pull his leg. Anything else? So we're once again ahead of time. So I think we'll break for lunch. And that will give us time to prepare for the advanced scenario that will follow shortly. No, thank you very much. So only the skills lab staff and the people that was involved in the scenario development will now be allowed in the venue. The rest, we would like you to excuse yourself and go and enjoy lunch. The VIPs, lunch will be served once again where the coffee and tea stations was. The students that participated in teams, you can ask Mrs. De Prier. She graciously sponsored a voucher for you to get lunch at Crisp.
next to the bed.
Okay, 100%.
I'm not sure which side. When Sister East.
And we all agree that the following teams are going through to the knockout round. Team 5, Bloody Angels. Congratulations. Team 10, Resus Angels. And then Team 8, Heartbeat Heroes. Then we also want to remind you that there's a competition going on in the background for the best dressed team. And then there's also a prize for the best upcoming emergency store that will be decided by the judges upon conclusion. That said, let's see if our live stream, we're just waiting for the production guys to see what's happening outside. And then I must just make sure that I dotted my I's and I crossed my T's. My H's and T's. I also have a tachycardia now. Ladies and gentlemen, we are going to ask the team from the Department of Emergency Medicine, University of Pretoria and Steve Biko Academic Hospital to join us and please introduce themselves. Are they coming in? Perfect. Where's your whole team? No, they must come here. I will tell them what to do. You see with these experts, some are thinking they're going to fetch the patient already. Thank you very much, Team Impret. You can welcome them. Kindly introduce yourselves.
Hello, everyone. We are Team EMPRET. So to my left here, we have professional nurse Linnell van der Veen. Then I am Wayne Grobler. I'm a registrar in emergency medicine.
I'm Almeen Smith. I'm also a registrar in emergency medicine.
I'm Jonathan King. I'm a consultant at Tembisa.
I'm going to say I'm Bobby. Yeah. No, I'm Anna Marie. I'm also a professional nurse working in the ED.
Team, the paramedics were called to a scene outside a nightclub in Hartbeespoort Dam. Apparently, there's multiple patients on scene. EMS found John Doe with a GCS of 9 out of 15, E3, V2, M4. The patient's intoxicated and incoherent. According to bystanders, a weapon, a handgun, was used and multiple shots were fired from approximately 1 to 2 meters away. They also found something that looked like drug paraphernalia next to the patient. The patient's GCS decreased on scene and he was subsequently RSI'd using fentanyl, ketamine and rock. They also did a single needle decompression on the right side for a pneumothorax. They were able to put up one large bore IV and they started saline for apparent hypotension. The EMS team said that they are leaving the scene now, seeing that the scene is not safe. The shooting started again. The weather was also deteriorating, and it will be a hot load off. Please select 2 members of your team to go and meet HEMS outside and accompany the patient to the emergency department. Thank you very much.
Okay.
We'll see you
Everyone,
just now.
please prep your trolley, prep some airway equipment for us, prep the defib, and let's get another IV line and possibly emergency blood. And remember to don your PPE.
LCP, do we have a live stream? Where are we going to see it? Geez, am I happy I wasn't sitting there now.
Okay, let's go. Okay, team, we
Okay,
have
team,
we have a
listen,
P1
we've got a very
polytrauma.
unstable patient. The heli was suffering during the bad weather that we had. So he's 26-year-old, male, multiple gunshot wounds. We assume that he's intoxicated. We found this little small bag next to him. So, yeah,
Okay, wait,
struggling to ventilate him there. We did a needle decompression before we took off right side. And then he's having a tourniquet for an active bleed on the right thigh. This is the bag that we found next to him.
Please put that on the side.
Scene.
Okay, let's expose the patient fully, please. Let's connect the monitors.
We've got decreased breath sounds on the right side, struggling to ventilate. BP is falling. The last BP was 88 over 55, pulse 148, and the SAT is 82.
Okay, SATS monitor is on. We have our ECG leads on. Can I get a BP on the patient? Okay, can we assess the airway, please? Is our ET tube in? Okay, so let's listen for breath sounds. Do I see any signs of chest trauma?
No.
Do I see equal air in equal chest rise?
Yes.
Okay, I'm going to auscultate.
No air entry on the right.
I'm not hearing any air entry. I think your tube is dislodged. Let's please remove the securing device. Make use of a video laryngoscope to try and evaluate placement of the ET tube. Okay. So then can we also prep a sterile pack for bilateral ICD insertions? I heard decreased air entry bilaterally. He does have a needle on the left side, so we're going to start with the left side. And then, Sister Linnell, we are going to connect a second IV line. He has one bag of saline running. Is a trauma patient. I'd like to start the patient on emergency blood so long. So please try and establish a second line. Okay. Are we able to bag the patient? Do we see any secretions in the airway, any signs of a jaw fracture, any loose teeth?
No, you don't.
Nothing? Okay. Do you see any chest rise?
With the back
Okay,
of
let's
mask, you do.
just see if we are getting chest rise. Okay, what is the current GCS of the patient?
He's paralyzed and sedated.
Paralyzed and sedated. Okay, so we are going to pre-oxygenate this patient. Let's start him on high-flow nasal cannula. We've already connected nasal cannula. I'd like to pre-oxygenate him using high flow. We're going to start at 30 liters per minute. We can go up to 70 at 100 at 100% FiO2. Okay. And then, Anna-Marie, can you please proceed to do a right-sided finger thoracostomy for us? We're going to use the fourth intercostal space mid-axillary line, making sure to just go over the rib. Remember, it is a sterile procedure. So we are hanging our additional fluid. Okay. You have an OP airway. You have an OP airway, and let's just get suction as well. We have rigid suction with the Yankauer. And then do you have your intubating equipment?
I do have my CMAC ready.
And do you have your ET tube?
ICD.
Okay, ICD is in on the right. Did I hear a gush of air?
Yes, the bottle is right on the trolley below. That's what's draining.
Okay, all right, so we're seeing blood. Did we start at 500 ml in the bottle? How much blood drained?
A liter drained.
A liter drained, okay, so it's a massive right-sided hemothorax. Let's get a cell saver and start auto-transfusion of the patient. Okay, ET tube is tested. Seems like our SATS has gone up to the highest we're going to get it. I think, okay, we called for cell saver. So we are starting auto transfusion. So let's secure this airway, please. Yes, we can. Okay, I have adrenaline. Let's give a 20 microgram push dose of adrenaline.
20 microgram given.
How much fluid did the patient receive prior to arrival?
2 liters crystalloid.
2 liters. Okay, so we're going to stop crystalloids from now on. We're only going for blood products. Yes. We're still sorting out the airway, but we can do, let's expose the patient completely and dry him so long while we get to that. Okay, we gave a push dose pressor. Do we have a new BP?
Busy monitoring.
Okay. And then at this stage, I'm also going to request Sister Linnell, can we just do baseline bloods? So that would be trauma series, including a CK. Let's do a type and screen for the lab and order a massive transfusion for the patient. And then can we also do an arterial blood gas as well? Okay, so let's fully expose the patient. We are going to cut this shirt off. Okay, blood gas is taken. Let's just wait for the new BP and then secure this airway. Okay, all right. There's a tourniquet on approximately on the right thigh. When was the tourniquet applied? How long ago?
Oh, it was applied on scene, but someone forgot to note the time.
Okay, all right. So this tourniquet is applied. Do I see any open wounds on the leg, or is it just bruising?
What you see there is what you got.
Okay, so I don't see a wound. I see bruising, but a swollen ecchymotic thigh. While we are doing our airway, okay, so our drugs, we can give cyclocapron 2 grams. For intubation, the patient's already been sedated and paralyzed. So we can give a low dose of ketamine on top of that to keep the patient dissociated. Let's opt for 1 milligram per kg. Do we have an estimated weight?
He's 75 kilograms.
Okay, so let's go for 75 milligrams of ketamine.
75 milligrams ketamine given in flush.
All right, and then we can give cyclocapron 2 grams as well. Yes, okay, let's proceed to intubation.
Check the DT tube. Cup is fine.
Okay, while Dr. Smith is doing intubation, I'm going to go on and do a... Okay, just provide inline C-spine immobilization for us, please. Okay, ET tube is in. We're going to check that now. Was directly visualized. I'm listening at the epigastrium.
No bubbles.
Okay, no bubbles. I'm hearing creps bilaterally, but there is an entry bilaterally. Okay, so there's creps bilaterally. We're going to go on to our circulation. I'm feeling for any pelvic instability. Is there any pelvic instability? Pelvis is stable. I'm feeling both femurs. Is there any femur instability?
There's something wrong with the left femur.
At the left femur. Okay, so I see a wound here medially. It's a 1 by 1 centimeter round wound, and I'm not currently seeing a second wound. Yes, let's connect the patient to a ventilator. We're going to do invasive ventilation. We are suspecting the patient has bilateral creps. There might have been aspiration. So let's do lung protective ventilation, volume control with a tidal volume of 6 liters per kg per minute. 6 mils. It's not 6 liters, sorry. Thanks for the correction. So it's a 75 kg patient, so let's go for 450 mils tidal volume with a PEEP of 6, and we can do a pressure support of 8. And let's start him on a high FiO2 of 100, and then we can titrate that down. Moving on to circulation. Okay. Do we have the blood gas yet?
First one you asked for is available.
Okay. So we have a pH of 7.2, P, CO2 of 33, PO2 of 55. The patient has a potassium of 5. I'm happy with that. Glucose of 5.5, lactate of 9, and an HB of 5. Okay. So we are addressing the hypovolemia. We're auto-transfusing. We are also giving the patient 2 units of blood products rapidly. At this stage, I would like to address this leg. We can't assess whether there is a femoral artery injury with the tourniquet in place. So I'm going to opt for controlled release but we don't have a time that the tourniquet was applied, right? Okay. All right, so let's phone vascular for a suspected femoral artery injury. I'm just worried about rapidly removing the tourniquet. We might have a reperfusion syndrome, which can cause a massive hyperkalemia and actually push the patient into an arrest. So for now, let's keep it here. The other leg is fine. Yes, let's repeat the blood gas. The GCS, can we check the pupils? Do we
Both equal, reactive to light.
Equal and reactive, okay. So at this stage, okay, our new blood gas, the HB has improved, lactate has improved. We have a hypocalcemic patient. Please let's remember to give calcium chloride 10 mils as well. 1 amp. Everything else seems to be improving. Nothing correctable on this gas, so please hand that back. At this stage, we are going to proceed to do exposure. So I'd like to completely expose the patient, get a temperature. Do we have a temperature?
This stage 35.4.
35.4. I'm happy with that. We can give that at the. We can do that at the secondary survey. Okay.
We'll just avoid that while
All right.
Can we cut?
Yes, you are welcome.
Okay. We're cutting the clothing. Just note we see vomit on the clothing as well as blood overlying a right-sided chest wound. Okay, so when we're ready, we're going to proceed to do a log roll of the patient. I'm worried about what might be happening on the back. And please just remove all of this now. Okay, and then I'd like to remove the shoes as well for adequate
The left
exposure.
leg is blue and mottled.
The left leg is blue and mottled. Okay. Do we have any word from vascular surgery yet?
Unfortunately, busy in theatre.
Okay. All right. So we're going to log roll to your side. I'm going to ask Almin to please manage the C-spine and tell the team when we can roll. Just keep in line C-spine immobilization. Okay, we'll do that now. Okay, I see we do have a dropping BP. So let's just quickly, before log rolling the patient, just reassess. Do we have any bleeding wounds on the head that I might have missed?
No, you don't.
Any wounds on the torso that I might have missed?
No, you don't.
And then we have this leg that is not actively bleeding.
No. The
Okay.
leg is just blue and
All right.
mottled, expanding hematoma.
Okay, so we're going to check the airway. I want to see that our ET tube is in place. We're going to reassess for air entry.
Our lines are still in, eh? Internal CO2. Fluids are still running. Warm fluid. Internal CO2.
Okay.
We did say we wanted it.
All right, can we please connect an end-tidal CO2? I think we have it here. It should be here somewhere. Okay, I don't want to get involved with that now. Okay, so our BP keeps dropping. We have good air entry. Our ET tube is in place.
Let's escalate our drugs to might be.
Okay, so at this point, I'd like to just do a sonar, make sure that we're not dealing with a potential left-sided pneumothorax as well, and also a cardiac tamponade. So
Your
I'm going on
sonographer has arrived.
Okay, so I'm going on the left hemithorax. Okay, I'm going at the at the heart, subxiphoid. Okay, I'm seeing good contractility on a 4-chamber, but there seems to be bilateral pericardial or bilateral pleural effusions. Do you agree?
Let's wait for dedicated use.
Okay. Can I get a, is this left? Okay, so this is right chest. Okay, so I am seeing lung sliding. Can I get the left chest, please? Okay, I'm not seeing any lung sliding. Let's decompress the left chest, please. Stop there. Okay, so I'm going to do a left-sided finger thoracostomy, sterile procedure, fourth intercostal space, mid-axillary line. I'm inserting an IC drain. Opening up with my finger. Do I feel a gush of air?
You do.
Okay. Is there any blood onto the bed?
No, not
Okay.
that much.
I'm inserting an intercostal drain and also connecting it to an underwater bottle, preferably a SimUPWars bag. Is there any
Perfect.
blood draining?
No.
Okay, so can we get a repeat vitals on the patient, please? Okay, and then while we're here, I'd like to further address the circulation, I'd like to perform an EFAS examination, checking the right upper quadrant first. Okay, I don't see any free fluid left upper quadrant or right upper quadrant. Pelvis. Okay, I'm not seeing any free fluid in the pelvis, so I'm thinking that it's the chest and most likely this leg. Our blood pressure is still dropping. We are giving blood. Can we start the patient on an inotrope infusion, please? So let's start the patient on adrenaline, 0.1 mics per kg per minute. Yes, we can give a push dose of 20 mics again. And then I'd also just like to review the IVC during my sonar to see for collapsibility of the inferior vena cava.
Collapses.
It collapses. So the patient is significantly hypovolemic. Let's continue the blood. Do we have any word on our other blood products, the FFPs and the platelets?
It's arrived.
Okay, so we can start a massive transfusion at 1:1:1 ratio. So we're going to give a total of 4 units of packed cells, 4 FFPs, and 1 mega unit of platelets. We can start the adrenaline infusion at 0.1 mic per kg per minute. Actually, we can start at 0.3 and we can increase. Let's get a urinary catheter in, please. And then I'd like to log roll the patient to make sure we're not missing any posterior wounds and external bleeding that we might be able to compress. Okay. Okay. All right. So, Linnell, can you just assist with a log roll, please? Okay. Okay, so on her call.
On my count, 3, 2, 1.
Okay, so posteriorly,
Oh, there's one.
I'm exposing the patient. Do I see anything on the scalp? Nothing.
Nothing.
Do I feel any spinal deformity?
No
Okay, so
slipping.
we see a wound on the right buttock that is actively bleeding. So right now we're going to do a compressive dressing. So please just keep the patient in that position. This is a compressive dressing. Are we achieving hemostasis with the compression dressing?
You do.
Okay, I'm going to do a PR for the patient. Do I see blood on the glove?
No.
What is the anal tone?
Normal.
Normal. Okay, so I'm happy with my back examination. We've achieved hemostasis here. Let's
Thank
please
you very much, Dr. and
turn the
team.
patient back. Okay.
You can turn your patient back,
All right.
and we can stop the scenario there. So we'll do feedback again after both teams have competed, and then we'll ask Dr. Safas Rousseau to specifically address the forensic evidence involved in this case. So you can take 2 minutes, stretch your legs. We're just going to prepare for the next team. So the 3 undergraduate teams, no, they can first. The 3 undergraduate teams, as soon as MPRET has finished their round and we've given our feedback and debriefing, you are please going to go with Ms. Menu to Hall 2, hand in your phones with her, sit there and wait to be called. Then I think we are ready now for Rocket. Ready. Okay, ladies and gentlemen, rockets outside. And en route, I suppose. Woo! Welcome, Team Rocket. Kindly introduce yourselves.
Hi, I'm Caleb. I work for Rocket, and that's about it.
I'm Johan. I also work for Rocket.
Hello, I'm Karin, and I'm a flight nurse. I work full-time for AirRescue, but I fly with Rocket as well.
And I'm Kate. I'm also a flight nurse for AirRescue, but I've also flown with Rocket recently.
Hello guys, my name is Sean. I also fly with Rocket. I'm not a pilot.
My name is Runel, and I've also flown with Rocket. Team Rocket, paramedics were called to a scene outside a nightclub in Hartbeespoort Dam. Apparently there's multiple patients on scene. EMS found John Doe with a GCS of 9 out of 15. E3, V2, M4. Patients intoxicated and incoherent. According to bystanders, the weapon that was fired was a handgun, and shots were fired from approximately 1 to 2 meters away. There was also some drug paraphernalia found next to the patient. Apparently, the patient's GCS decreased on scene and he was RSI'd using fentanyl, ketamine, and rock. They also did a single needle decompression for a right-sided pneumo on scene, and they were able to put up 1 large bore IV with saline for apparent hypotension. The HEMS team reports that the scene is unsafe, that they have to leave immediately. The weather is also starting to get worse, and it will be a hot offload. So you can prepare your team, and please send out 2 of your members to accompany the HEMS team to the emergency department. Thank you.
Yeah, I'll go for it. Okay, let's set up a chest drain set, have one ready, and then we can also just prep some blood and fluid. I don't know where those things are.
When in doubt, ask a nurse.
You know, ask the smart one. Yeah, let's pop it up here. We can have it ready to go. If we have time enough, maybe we can just drop some meds as well.
Is this how Hello, Sean, Johan. Right? You can start talking to us. Start talking here. Going to do a proper
What's the code for this thing?
The sonographer is not here yet. She'll join you shortly.
We don't need a sonographer.
She has the password. Woo! And here they come with the patient.
Okay, guys, this is a 26-year-old male, multiple gunshot wounds. We think he's intoxicated because we found this little small bag with paraphernalia next to him. I'm not just sure where the bag is now. No, no family. So before we took off, we did a right needle decompression.
Okay, team, just
for
pause
poor
for 2 seconds. Let's
ventilation,
listen to handover.
But we struggled to ventilate the patient still. He's actively bleeding from the right.
Won't you check
so
that
we,
bleeding? Have a look, Johan.
Have it applied a
Check the
tourniquet
massive
there.
bleed for us.
The last BP was 88 on 55, pulse 148, sats 82.
Okay, guys, we're going to start at the top.
BP is falling and he's having one line ACF.
Cool, Johan, will you
with
check
normal
tube
saline.
and tube placement? Let's get end-tidal CO2 on top there, please.
The tube is not begging, there's a lot of resistance.
Okay, cool, take it out. Let's BVM ventilate. Oh, don't take it out just yet. Just have a listen to the chest for us.
Right. BP cuff sets.
A lot of resistance.
On.
Air entry. All right, we have to actually listen. You need to listen, Karine. Okay. Do we have the end-tidal CO2 on the tube yet? Let's pop it on. Is he moving at all? Yeah. Any active bleeding that I can see now?
Have we got end-tidal CO2? No.
What kind of unit is this? Okay, please will you just do a quick assessment for active bleeding so we can get control of that?
I just want to push the bleed.
Okay, what did you hear on air entry, Karine?
Brake is on.
Okay, so there is a bullet wound at the top there. Cool, and it's on the right-hand side. Is the right side of the chest moving at all? There's a needle. Is the right side moving at all?
Nothing on the arms.
Not great. Okay. Have we got a blood pressure yet? Okay, cool. Let's decompress that right side. I think it's safe to.
Change it to. I'm worried about it. There's a lot of resistance.
I think we might have a tension. So let's decompress and then we can worry about changing the tube. Fantastic. Let's do a super quick head to toe, Sean. Okay.
I've done the chest. There's an open wound.
Yeah, do a finger. It's good.
You want me to check?
I want you to check the head. Anything at the head that we can see? Bleeding, bruises.
Nothing obvious.
Okay, cool. Chest, we've got the gunshot. Air and blood. Is the BVM better to ventilate on now?
Not much.
Not much. Okay, take it out. Let's BVM ventilate.
Okay, I'm out of the way. I've checked the chest.
Okay, only the one bullet hole. And we must just remember there's probably an exit. Abdomen. How does it feel? Soft. Pelvis, do we see any wounds or anything? Just open the shorts, let's look.
Wounds as you find them. Pelvis feels stable.
Feels stable. Is this a
I
wound?
don't see any.
Okay.
There's a tourniquet here.
Okay, tourniquet is on and we've got quite a big abrasion there.
Right,
Awesome.
we'll cover.
Okay, guys, let's pause for a second and start right at the top again. There's no active massive bleeding that we're worrying about. Airway, what's happening at the airway?
So there was obstruction in the tube.
Okay, let's get equipment ready to re-intubate and just have a quick look at level of consciousness and are we going to need to worry about giving him some drugs before we pop that in, Johan?
Is the entry good with the mask?
It's okay.
It's okay. Our sats haven't really changed at all. Are we connected to O2 there? Okay. Okay, connected to O2. Okay, let's re-listen to the chest again and let's just see if we've got any change in what it sounded like. Okay, good two-handed seal, Johan. Let's get some good ventilation on breath every 6 seconds. Okay, I can see both sides of the chest rising, so we've got some good air entry. Good job. Okay, peripheral pulses and central
As you hear
pulses.
I'm deaf in the one. I just rather let's do it.
Okay, so
Kate, can I ask you to please start a fluid bolus? Do we know how much he received pre-hospital?
about 2 liters apparently.
2 liters. Okay, hold on the fluid. Let's just start some blood and FFP. We'll just do massive transfusion for him. And can we get some TXA into him as well, please? 1 gram, Kate. Okay, how are we doing on his chest, guys?
Decrease on the right, an entry on the left.
Decreased on the right. Still moving.
But you
now.
have air entry on both sides.
Okay, cool. And that little finger thoracostomy that we had, we'll just keep using that to relieve pressure right for now. if we
Air and
need to.
blood each time.
Okay, fantastic. We'll formalize the chest drain in a second.
Moving the bed down.
Okay. Guys, I want to first get him hemodynamically stable before we think about intubation. So we're going to just optimize oxygenation. Let's get a nasal cannula on, 15 liters per minute. Let's get a PEEP valve on at 10 centimeters of water, and we've got 15 liters per minute running through the BVM. Let's get him slightly head up. I know his C-spines are concerned, but we're not going to move his C-spine at all. Okay, we're going to optimize his perfusion. We've got blood running, and we've got massive transfusion protocol in the background sort of coming through. Kate, can we please just get an adrenaline infusion? Let's do 3 amps and 50 moles, and then we can start him at 0.1 and just get some kind of blood pressure before we smash him. I'm sure we do. Does he have any swallow response, Johan?
It appears he's still paralyzed.
It appears he's still paralyzed. Okay. Cool. Just have a look at his eyes. Do we have any tearing, and what's the pupils like? Is he tearing pupils?
No, he's not tearing.
Okay, and pupils?
As you see them.
Okay.
There's no eyes there.
Oh. Pupils equal constricted, reacting sluggishly.
Okay, so we're not super worried about a brain, eh? Are you? And we've got paralysis in place already. No peep valve. Okay. Cool. Have we started our adrenaline yet? Okay, fantastic. Johan, you're going to just keep ventilating, giving us good feedback about what's happening over there. In the meantime, can we maybe get the ultrasound going?
The only wounds I've seen, like I said,
That and that. Okay. This one's not actively bleeding still, hey?
No, they're not actively
As it
bleeding.
is.
There's some blood under the patient. But
So behind him, we probably have a bleed that we need to worry about. Okay. Okay, cool. Yeah, I'm happy to. Okay, let's do lung sliding. Okay, good. We've got lung sliding there. Okay, it's the other way around. Right, okay, so we've got absent lung sliding on the right. Cool, let's just do a super quick abdo. Left side.
no, that was correct. It's absent lung sliding on the left.
On the left, but we're hearing air entry on the left.
Absent lung sliding on the left.
Okay,
let's decompress
do a finger on that side as well. Abdomen.
Okay. And you finger then?
Okay.
I need somebody back.
Don't see any free fluid. Over the abdomen, over the bladder.
Okay, so
No,
deep compressed
okay,
on the
cool.
left.
Just air.
Just air. Rush of air?
Some air.
Some air, okay. Adrenaline is at running, and has it done anything to our vitals at all?
Adrenaline's running.
And blood is running, and fresh frozen plasma is running. Awesome. Johan, can you do a 0.25 milligram per kilogram dose of ketamine, just for that BP, and I think we need to get that airway under control. Then we'll formalize those chest trains. Kate, if I can ask you, just keep decompressing that chest for us as we go along. Okay, guys, we've got a change in rhythm. Let me check for a pulse. Cool, let's drop the bed. Let's start some CPR. Let's get you a step.
Can I put in an LMA?
Yeah, go for it. Johan, get ready to defib. Okay, guys, we're going to do a pre-charge. So we're going to charge up to 200 joules. Yes, I do. Okay, we got a step for you, Kate. Is there any way we can get end-tidal CO2 from somewhere?
Go and look in the storeroom.
They probably came with, the heli probably came with, because they always have more equipment than the EDs do. Okay, let's get going on that defib, Johan. We are 25 seconds into our resus. Sean, while we're waiting, can I ask you to draw up adrenaline so we have it and ready? Okay, let's charge up. Yeah, your pads are not working again. Let's go to paddles.
Right. I get 4 inches for now, no? 120, that's fine.
Yeah, just hold off on the adrenaline for now.
Okay. Where's our IV side?
Okay, let's just, Sean, help me run through the H's and T's we have to worry about for this patient. We can just tube this guy now, or LMA.
We've got LMA.
Fantastic.
Already got it in.
Okay, we've got lines up both sides, we're running fluid, we're running blood. We've given TXA. Chest was clear, abdo was clear, didn't see any free fluid. It was just the lung sliding disasters. Hands off.
What about toxins?
Okay, we're non-shockable. Go back to chest compressions.
Can I turn around and go there behind her to take over? Then we can do HSLTs.
Pupils were super constricted, hey?
Because you saw it. Okay.
Pupils were really constricted.
I didn't see that.
I'm gonna hold on to the naloxone for after we get a pulse back. Don't worry about that.
That's what we
Yeah.
discussed.
In my infinite drug experience, I have no idea what this is. You're gonna know. I will tell you, we are 10 seconds, guys. Johan?
Does the color correlate?
Johan, 10 seconds. Pre-charge. 5, 4, 3, 2, 1. Okay, we're not shockable. Let's check a pulse, please.
Check a pulse.
Just check a pulse for us. No pulse. Carry on with CPR. Fluid and blood, has it finished? Or still running? Fluid and blood, still running. Okay, great. Let's formalize those chest drains for us, please, Johan, if you can, while you're there. And we're probably going to have to think about opening his chest. Yeah, on the next rhythm check, we'll see if we can get a look at the pericardial effusion. I didn't look at the heart, though. I'm going to just prep it.
Can I stop?
No, just carry on. We're going to stop on the next rhythm check. I don't see a massive effusion. But also it's, during CPR we're not going to see it mostly. Is the heart actually moving in cardiac arrest? Because on that picture it's moving. Okay, cool. Okay, so we've got a pseudo PEA. This is volume, guys. Okay, what's the total volume of fluid that we've given so far? Of our fluid? And 1 ringers. I think let's do plasma and maybe some more ringers for now because he's dead. Okay, we are 30 seconds to the next rhythm check. And Kate, while you're standing there, we can drop and get the adrenaline ready after. We can actually give it now. Okay, perfect. 15 seconds. 10, 9, 8, 7, 6, 5. You can jump off. Let's have a look. Non-shockable. Do we have a pulse? No pulse. Is there a pulse? Okay, so apparently there is a pulse. Let's stop right there. Let's disarm the monitor. Kate, let's disarm the monitor. Okay, let's start at the top. Airway. Corinne, how are you happy with the airway? Is the chest rising nicely on ventilation? Do we have anything in the airway that we need to worry about? Okay, let's have a look at the chest. Have a quick listen. Are we sounding better on the chest with the bilateral thoracostomies and now a formal chest drain on each side? Cool. Kate, why don't you push the blood pressure button for us? Oh, there we go.
What you also see is it looks like there's a lot more blood lying
Around him. Guys, let's quickly flip him because he's bleeding at the back. Okay, so we've got A and B. We know C is a disaster. We're going this way and you are going to manage. We just need another person this side, Sean.
On my count.
And we can't turn him like this. We need another person this side. Okay, you ready to pack that wound, eh? Okay, when you're ready.
1, 2, 3.
Okay, we have a large.
Oh, he's got a butt
On
wound.
the butt. Applying
Cool, if we apply pressure, does it stop?
Okay, so we're plugging it.
Cool, so it's bandaged and plugged.
Stop
no
now.
oozing, no leaking around the bandage. Okay, fantastic. Let's pop him back.
Okay. Can we go back? Yes, you're 1, 2, 3.
Awesome.
There's also a lot of oats underneath.
A lot of oats. Okay, what did the chest sound like, Johan? Were you happy?
It sounds good.
Sounds better. Bubbling on both sides. Any more blood coming out?
There's this amount of blood.
That amount of blood.
On
That
this
is quite a lot of blood. Are the surgeons ready for us? I did. You weren't here.
You activated them whilst we were waiting.
Yeah.
No, they're still not here.
They're still not here. Okay. Let's do a quick blood gas, get a calcium, and see if we need to replace calcium we've given TXA. What do you think?
I didn't.
Do a quick glucose.
Top draw, second draw.
Hey.
Second draw was top draw.
Okay, guys, our blood gas, we've got a pH of 7.29, PCO2 of 34, PaO2 of 77. Is that right now or was that earlier?
About 20 minutes.
Okay. HCO3 of 21, potassium of 4.3. I'm happy with that. Calcium is low. Let's do a 10 ml dose of calcium, please. Glucose is fine, lactate is high, HB is 8.
Stop there.
Thank you. Thank you so much, Rocket. You can take a seat, and then as with the students, we are going to do your debrief. And I would like to turn to our expert judges now, whom I've neglected to introduce earlier. So whilst everyone is getting their seat, I would like to tell you a little bit. Thank you so much. So Dr. Safas Rousseau, joining us today, is a forensic pathologist attached to the Gauteng Department of Health, the Director of Forensic Pathology Services, as Head Clinical Unit and Senior Lecturer in the Department of Forensic Medicine, Faculty of Health Sciences, University of Pretoria. He's currently the acting head of the Department of Forensic Medicine at UP. He is involved in the medico-legal investigations of death in the northern Gauteng region for the past 31 years and has vast experience of medico-legal work, including court duties. Autopsy work includes fatal causes of trauma and poisoning, as well as sudden unexpected death cases. Trauma-related cases include fatalities due to gunshot wounds, blast injuries, stabs, incised wounds, blunt force injury, electrocution, burns, and transportation injuries, including the aviation fatalities. You don't want to meet him. He has testified as an expert witness in the Magistrate Court, High Court, Military Court, South African Police Service disciplinary hearings, and the HPCSA disciplinary hearings. He also acted as an external assessor in numerous court cases, including inquest and criminal cases. Thank you very much for joining us today, Doctor. Our next expert independent judge is Dr. Leanne Frankish. She, now I can say her correct title. She's a specialist anesthesiologist working in private practice. She's also an UP alumni, where she completed her undergraduate studies in 2008 and her postgraduate MMed in anesthesiology in 2019. Leanne's passions are pediatric anesthesia, simulation and education, and she's currently busy completing a diploma in simulation through the University of Johannesburg. Dr. Tammy Bailey-Stanton is a Durban girl, married to an awesome guy, Dave, that you just met here in front. She loves reading, her cats, interior designs, graphic novels, arts and crafts projects, and all things fancy, including tea and chocolate. She's a specialist emergency physician, a lecturer for the Department of Emergency Medicine at the University of Witwatersrand, and her MMed was on point-of-care ultrasound in the emergency department. She's the boss of the emergency department at the Rahima Musa Mother and Child Hospital. She is primarily working in the pediatric emergency department, but she also conducts, or is also involved in women's health emergencies. She does calls at the ED at Helen Joseph Academic Hospital, and she also works in the ICU at Chris Hani Baragwanath Academic Hospital. She's a consultant for Netcare 911, and she's faculty for the Resus Council for South Africa, and as she says, for her sins. Welcome, Doctor. Then Dr. Dani, you've seen him here the whole day. Dr. Dani van der Merwe, qualified as a medical doctor, MBCHB, from the University of Pretoria in 1991. From there, he proceeded to work in the Department of Family Emergency Medicine at Kalafong and Pretoria Academic Hospital, obtaining his MMed in Family Medicine in 2000. He also worked as supervising medical officer with the Gauteng Emergency Medical Services and obtained a diploma in primary emergency care, the highest qualification in emergency medicine in South Africa at that time. He spent the next 5 years in Canada, working in various major emergency departments in Manitoba, British Columbia, and there gaining valuable experience. Upon his return to South Africa, he spent the next 10 years working in various emergency departments in Pretoria before successfully taking over the newly established Mediclinic Midstream Emergency Centre. After 5 years at Midstream, he teamed up with colleagues Dr. Bianca Vermeulen and Dr. Skalk Augustine, and they opened a brand new Raslouw private hospital accident and emergency department. Dr. van der Merwe is also a qualified airline transport pilot, and he flies for air ambulance services in his spare time. Thank you very much for joining us. And that said, I'm going to hand over to the judges to give us a debriefing of these two teams, and then I'll open up the floor for the rest of the panel. Thank you, Dr. Stanton.
Hi, can you guys hear me? Okay, so let's give the two teams a big round of applause. Woohoo! Showing us what we want to aspire to one day. Okay, cool. Thank you guys very much for the efforts. I hope that you are still alive after performing in front of all of us. It's stressful. I'm sure the students who are still here know it's pretty stressful with everybody watching. I loved the trauma approach. I thought it was really cool. Both teams showed that really well. So that's my general feeling. So I don't know where the two teams are. I can't see. Do we have the teams at their back? Ah, okay. How did it go for you guys? That's yeah. Great. Yeah, a little bit more.
Hello. So I think we did well. We had a solid approach, started with airway. Dr. Smith took control of the airway, and while she was doing that and we were pre-oxygenating the patient, we went on to breathing, established the right-sided pneumothorax and did a finger thoracostomy. We unfortunately were a bit slow in establishing that there's a left-sided pneumothorax as well.
Yeah, I came a little bit on the late side, but you got there, right?
And I'm happy that we asked for drain output and saw that it was a massive hemothorax and that we were able to start auto-transfusing the patient as well. We didn't, just mentioning the breathing, we could have gone back and reassessed the breathing when the patient started deteriorating again. In terms of circulation, we established large bore IV access. We opted to keep the tourniquet in place as there was no active external bleeding, so that was controlling our bleeding.
Can I say, there was some really nice conversation actually going, because you initially decided that you were going to do a controlled release, and you got some really nice feedback from your team. And your team was like, are you sure you want to do that?
Yes, thank you very much,
right?
team.
So that's a really nice thing. You didn't just plow ahead. Actually, there was good communication. It wasn't a fight, but you took the advice of the wiser people on your team, and I think it was the nurses, right?
Yes.
Always is the nurses. They always know better than us. It's true.
They are the ones who taught us.
Yes,
all.
exactly.
So,
Right.
yes.
Okay. Yeah.
So in terms of circulation, we started blood products. The patient had already received a large amount of crystalloid. So in this case, there's no role for further administration of crystalloid. So we gave the patient blood. We auto-transfused.
So I loved the auto-transfusion. That was really cool. All right. So if you've got access to auto-transfusion in your unit, what did you specifically ask for?
We asked for a cell saver.
Okay, so if you've got access to a cell saver, fabulous. If you don't have access to a cell saver?
So we, in our unit, we have Sinapi. So we use the Sinapi IC drains, and those ones you can just directly connect to a blood-giving set and auto-transfuse.
Nice, and for those of us who are poor and work in really poor hospitals, what could we have done? If you don't have a Sinapi or a cell saver?
I'm going to phone a friend.
Okay, you've got a consultant on your team. Is he still around?
Yes, I'm still around.
Awesome, tell us.
So depending whether you drain the blood into blood and water, but if you just drain it into blood, you can add 10 units of heparin and transfuse it back into the patient.
What kind of water should be in the
It should
bottle?
obviously be a sterile water.
What's better than water?
Saline.
Saline, right.
Yeah.
So if you're in a really poor environment and you're expecting a massive hemothorax and you can't auto-transfuse because you don't have a fancy cell saver like they do in theatre or some of the big units, right? Having access to heparin, we all have heparin in a hospital, and if you've got those old-fashioned underwater drains, be smart about it. Put saline in with heparin first. It can make a difference when you don't have easy access to blood. Okay, that was one really nice thing you guys do, auto-transfuse. That was awesome. Okay, how to keep going? Sorry, I derailed you there.
No problem. So we did, I didn't really ask for active, if we see active bleeding from the chest wound, which we could have done to apply a compressive dressing there. And then...
Did you verbalize it? I think I missed it. The gunshot on the right upper chest.
Yes, we did.
You verbalized, okay, that's
We
just me.
verbalized that there
My
was
bad.
a wound. I didn't describe the wound.
Okay, all right. So if you think about that for documentation purposes, and that's something we're going to come to a little bit later, for the person who's taking notes, you want to document what kind of wound it is, and you need to call it out in the recess. Okay?
Yes.
Yeah, cool.
And then in terms of circulation,
I think that was it. We also opted to, at this stage, do an EFAST, look for any intra-abdominal free fluid, which there wasn't. We did a cardiac view as well, and on that we could actually see that there was bilateral pleural fluid. So I think that prompted us to reevaluate and actually go for the left-sided drain
And
as well.
figure out why your patient was deteriorating.
Yes.
And the BPs were dropping and dropping and dropping.
Then in terms of the disability, the patient was relaxed. We opted to give another dissociative dose of ketamine. As we have a relaxed patient, we don't want to be intubating and basically managing a potentially awake patient who is relaxed. So that's why we opted to use a dissociative agent for intubating.
So just on a technical note,
Yes.
what was the time frame between this dose, the intubating dose of rocuronium that was given on scene, and you're giving the ketamine?
We didn't establish that.
Okay, so that's just something to think about. Still potentially, if you're going to RSI, do it. I know the patient was relaxed on clinical assessment, but if we have a patient down the line that doesn't have a muscle relaxant on board because we haven't thought about it, you need to be worried about that. So it's not necessarily a criticism, but verbalize why you are or you aren't, and then you come back to it later, right?
Okay.
Head injury, you want to worry about it as well.
Yes.
Okay.
So we assessed the pupils. They were equal. They weren't reported as being pinpoint, if I remember correctly.
They were reported as not being reactive because the muscle relaxant was still working in this patient.
Okay. So then we went on to exposure. At that stage, when we wanted to do the initial log roll, the patient started deteriorating, which prompted us to stop and reassess. At this point, retrospectively, we should have proceeded with the log roll to look for any posterior wounds, which we did find when we eventually did do the log roll. So we found that actively bleeding right buttock wound, so the patient had likely an open pelvic fracture that was bleeding externally, so we addressed that with a compression dressing. And then basically before we got to secondary survey, we were out of time. So.
Okay, don't stress about that, guys. We have to end it somewhere, right?
And we kept the
If we
turning
follow
down,
it through, it's probably going to take us about a full 2 hours with the surgeon arriving and everything going. All right, so thank you. Just from the team's perspective, how did your team leader do? Okay, so from the audience, what did you guys think just about the noise and the stress levels that you, as a witness, felt when you were watching this recess? Anybody that's feeling brave? I'm looking at you guys because you're just behind me. What do you guys think about the stress levels in the team and the communication?
Organized and well orientated. Sorry, I'll speak some more. So it was organized and well orientated.
Okay.
They didn't add extra stress to the whole situation. It was calm and under control, and that helps a lot in these situations.
And the direction of the feedback to team leader, they did. There were a few steps along the way. It wasn't just the tourniquet. There were other things. There were wise pieces of advice given, but they were directed to team leader. So instead of just being chaos with everyone shouting and screaming like a total mess, it went really well, the communication. And they kept the stress levels under control in a nice, calm, slow manner. Okay, that's my feedback.
Thank you very much. Dr. van der Merwe.
Yes, thank you very much. Again, well done to both teams working under this amount of stress. We saw from one of the students, one team leader, how hyperventilation looks like. And I think that's a real challenge. The one time I had to do a presentation and I actually started hyperventilating myself. And knowing what it feels like, I could reverse it, but otherwise you're in trouble. So the compliment to both team leaders, I think they established roles and they took leadership and they had continuous feedback from the team members and they revisited the ABCs the whole time. I think the big thing that we can easily do in a complex patient like this in the environment is we lose track of where we are. And if you're unsure, just go back to your ABCs. And this is what they both did very well. And they used POCUS, which I don't think everybody is already using it, so this is a really good step forward. And then, yeah, so the only thing that I think that was the delay in both sides was the finding of the penetrating wound in the right buttock. And again, with a mannequin and a real patient, you can just see the bedding starting to get soaked in blood in a mannequin that's kind of stationary, so it doesn't really attract your attention and urges you to do the lock roll. But it just shows, I mean, it can catch out, and I think that's probably the only thing that was delayed on both sides. But apart from that, I really enjoyed watching them going. I mean, I could just imagine the amount of stress they must have having to perform in front of all their peers. So I think job really well done, guys.
Thank you. Dr. Frankish?
Hi, Dr. Frankish. What I'm going to ask is if you're able to do some feedback, that'll be awesome. And if you're not going to individually feedback the team, I'm keen to do that part, if that's all right, to debrief. Is that okay? Perfect, cool.
Yeah, so I think... Hello, does it? Yeah, I think my colleagues have basically said everything that I'd also noted. It was really good to see your teamwork, and I think your communication was the closed loop, which was something that we saw was slightly missing with the undergrads. This is where you get to when you have been a team working together for a very long time. And actually saying, and I noticed it more with Rocket, when you call someone by their name, if you say, someone get me a blood gas, it's not going to happen. But if you say, you know, so-and-so get me a blood gas, that closed loop communication was very, very well done. But I think, yeah, big ups to both teams. I think you guys did brilliantly. Well done.
Okay, so Rocket, how did it go?
I think it was okay. This unit is not one I'm going to visit again on purpose. All the missing equipment is just very sad. But I think we try to stay as systematic as possible. There were a few times where there were things that we wanted to do, but then things changed, and then we ended up coming back to them a bit later, so specifically the bleed. And like we had said, there's going to be a bleed at the back. Let's come back to it, and then the patient arrested, and you just kind of forget about it. But at least he's not bleeding when he's dead.
It's hard to lug roll a patient and do CPR at the same time. Sure.
I wish that I had done a pericardial view before the CPR, and I just wanted to rule out, I mean, because I felt like the chest was the problem, so I just assumed it would be a problem. But I think that would have made it easier to assess in the cardiac arrest, and we would already have known that we didn't have to worry about the heart at that point.
It's nice to do, if you're doing an intervention, to do it from beginning to end. And it's so easy to be distracted. You find a problem, fix it, and we must, right? But then the person doing the sonar must carry on with the rest of it. It's the truth, right? You don't want them to do it and then forget about the intervention. So they beautifully acted on it immediately. But the person doing the skill must do the skill, and the other person must carry on with the sonar. Okay, yeah?
Yeah, and I know that at one point I definitely overloaded poor Kate, but she's amazing.
She's tough, she can take it. And I hope the juniors in the room are hearing this. When your senior nurse tells you something, doctor, are you sure that you really pay attention to what they're saying, okay?
Yeah, and then I think thank you to the team who were amazing. I don't know if you guys want to add something.
Okay. How did you guys feel about the leadership? Okay, really nice, clear, sort of calm, direct instructions. Chat to me a little bit about this cardiac arrest. The reason being, and we're all very interested in the audience, because the first team didn't actually have a cardiac arrest.
So for me, it was a bit confusing because the left side of the chest I could physically see moving. So it was very difficult to reconcile that with attention pneumo. So the clinical signs and symptoms didn't match what you wanted us to find, which is, it happens in some.
Tricky in some, right?
Yeah.
And I think you guys have touched on it already. It really is. It's so important when you're prompting. So in the back of your head, you're like, oh, we should have prompted it like this.
Yeah, so I thought they might be bilateral, but I could physically see both sides of the chest rising. The cardiac arrest, I think, was probably a hypoxic/hypoperfusion cardiac arrest. He went into a pseudo-PEA, so probably a volume and hypoxia issue.
Okay.
And once we sorted out the left side, it came right pretty quickly.
Okay, so we definitely had some respiratory issues going on. We had some massive hypovolemia, all right? But we had some other things, some other confounders. The patient came with a baggie with some weird paraphernalia.
With the drugs that were on board.
Yes, and I love it. It's so formal, drug paraphernalia. For us, it's usually just a crack pipe, right, that you find in the pocket. Okay, so do you want to reconsider a little, maybe?
I don't think that I do, because if it was an opioid, I probably would have left it alone, and I think we would have just ventilated the patient out of it. I don't think that it was necessarily a stimulant based on the presentation, though it could have been. What would I treat that with anyway?
Yeah.
I think I would monitor and I would assess, and I don't think that would have caused the arrest. I think it's more likely hypoxia.
Okay.
Am I wrong?
I think this was a multifactorial arrest. I didn't design the SIM, so I'm looking at the SIM team, but it is a multifactorial arrest, right? We've got a hypotensive patient who is hypoxemic that we're busy resuscitating the crap out of, but there are stimulants on board. This is a patient with stimulants on board. What exacerbates dysrhythmias or makes patients more prone to having a dysrhythmia?
A stimulant and an agitated myocardium.
Sure, okay, all right. Maybe he was smacked in the chest, but I didn't get that history. He was shot, right?
Yeah.
Okay. Other things that can precipitate a predisposition to a dysrhythmia? They did find it.
The drug?
No, so electrolytes. Okay. So here's the thing. If you add a stimulant to a stimulant, potentially we all chose ketamine, both teams did. It didn't really do much. The heart rate went up very slightly for the one experience, and I think the other experience.
We didn't even get to the ketamine.
Yeah. So that's not really a consideration. But things that are going to exacerbate dysrhythmias, hypoxia, right? Yes, tick. Hypovolemia, tick. A really irritable myocardium that is having an adrenaline infusion starting, right? Tick. And now we've got a significant electrolyte abnormality. In this patient, we had a hypocalcemia. And I'm guessing, although it's quite rare for us to see a torsades, cardiac arrest, and a traumatic arrest, the same as what Prof. Engelbrecht was saying in the first SIMS with the students, it's rare for us to see a different rhythm, a shockable rhythm in a traumatic cardiac arrest. It's usually big bleed, hypovolemia, hypoxia, we've got to sort out the big stuff, coagulopathy, all that. So I'm just trying to make sense of why this happened. And sure as hell, I think that's probably what it was, right? This patient had some stimulants on board. We were cold, hypovolemic, shocked, and we hadn't yet found the hypocalcemia. Yeah, totally. And the drug of choice, right, for torsades?
Magnesium.
Polymorphic VTAC is magnesium, yeah. So he's probably a chronic alcoholic, that one.
He was literally in torsades for about 12 seconds, though. It disappeared.
Yeah, for sure. But it was there, and we're all curious about it. That's why we're talking about it. Everyone's thinking, why did that patient arrest? Okay. Yeah, thanks. That's from me.
Cool, thank you.
Okay.
Thank you. First of all, thank you to both teams for keeping the patient alive, not transferring him to me. Earlier today it was said that I only nail them when they're alive. But in my case, I only touch them when they're dead. So in this cases, there are basically three medico-legal perspectives or aspects. Number one is the wounds.
are the wounds, the description of the wounds. Then toxicology. Toxicology is always important for us as forensic medical practitioners. And then documentation. So as far as the description of the wounds are concerned, team number 1 described or mentioned all the wounds on the chest, on the left thigh, and as well as the right buttock. However, only one wound, the one on the left thigh, a measurement was given, 1 by 1 centimeter, which is important. Now, I'm the first one to admit, I also, when I was still a real doctor, worked in emergency medicine across the street. So I know, and I appreciate that your number 1 priority, and maybe only priority at that stage, is to treat the injuries and to save the person's life. However, later on, and sometimes years later, these things tend to come back because court cases, even if a patient stays alive, that doesn't mean there will be no legal action afterwards. There can still be criminal charges, attempted murder, and so forth. And then in court, this becomes very, very relevant, the description of wounds. So always, as I said, after patient is stable and, if at all possible, describe the wounds. Call it, as it was mentioned, gunshot wounds. In this particular case, there was a history of shooting and a handgun or firearm found in the proximity of the patient on the scene. So we do not know at that stage exactly what type of firearm or handgun it was and what caliber, which obviously is also important. Nevertheless, try to describe the wounds. First of all, establish whether it is gunshot wounds or not. If you decide it's a gunshot wound, then try to establish whether it is an entrance or an exit wound. Then correlate the wounds. Count the wounds and try to correlate which are entrance and exit. And if they don't correlate, in other words, if it's an uneven amount of wounds, that means there must be a projectile or a bullet somewhere in situ in the body, which can, in a living patient, then obviously be visualized with the use of radiography. We incidentally also use, believe it or not, radiography at the mortuary to identify projectiles in the body or to locate them, because we, the clinicians, emergency medical practitioners and surgeons, they have an excuse not to remove bullets from the body because it can cause more harm. Whereas we, as pathologists, we have no excuse. We must find the bullet, have to remove it because it's evidence. So it is important, the description of the wounds, to decide whether it's entrance, entrance or exit. As I said, later on in court, it will be important to establish for legal purposes from which side, from which direction the person was shot. And to determine which was a shooter, the guilty person or not. And then also things like to try to establish whether it was a suicide or not. So in that case, the distance at which a shot was fired is also important. So things to look at to decide whether it is an entrance wound. The characteristics of a typical entrance wound are a central punched out defect because of the total destruction of the skin tissue in the center of where the bullet or the projectile actually penetrates due to kinetic energy transfer. Then secondly, the so-called ring of abrasion, which is not really an abrasion, but it is called abrasion because it looks like an abrasion, but it is actually due to the hydrodynamic event and energy transfer that gives rise to the formation of the ring of abrasion. And then just on the inside of the wound, you get the so-called dirt collar or the smudge ring, which is simply impurities on the surface of the bullet that wipes off in the center on the rim of the central punched out defect. In additional features, the so-called ring of contusion due to subcutaneous hemorrhage directly in the area of the wound, also due to rupture of small blood vessels as a result of the hydrodynamic event. And then additionally, tattooing and smoke or soot discoloration, all depending on the distance at which the shot was fired. So smoke and soot, they usually cause a dark grey discoloration around the entrance defect, whereas tattooing are small spots. Tattooing is actually caused by propellant residues. Because in modern ammunition, it is not the powder, it is small particles, the nitrocellulose propellant in modern firearm cartridges. And not all of them actually burns or burn completely when a shot is fired. Therefore, if fired at such a range where that particles can still reach the body, where it will be embedded on the body. Each particle causes a single little defect in the epidermis. So that is what you can use to give an indication of a distance at which a shot was fired. You must remember, secondary entrance wound, we have a primary target. You will not see that, even though the shot may have been fired in relatively close proximity. Close also. If a person, like this person most probably, if he shot through clothes, obviously the smoke and soot and even the propellant residues will be absorbed by the clothing, and then you will not see it on the body and make the mistake of interpreting it as a distant gunshot wound. So the point is, you always have to determine or interpret with caution your findings in gunshot wounds. Exit wounds, usually irregular, not usually round or punched out, but there are always exceptions to the rules. I always tell it as undergraduate students, in medicine, there are more exceptions to the rules than rules, actually. And then another important feature to determine whether it is an exit wound is the wound edges are actually approximable. So they will fit in like a jigsaw puzzle if you push them together. Because at the exit part, the projectile has lost much of its muzzle velocity. In other words, less kinetic energy. In other words, it literally stretches the skin and ruptures it, almost like a blunt force injury, but it isn't. Then, as far as toxicology is concerned, we forensic medical practitioners like toxicology, and we routinely retain blood samples at autopsies for at least ethanol. So we would like, since you obtain blood samples for other tests, prefer to just do a tox screen, including ethanol, especially if you know that person was transported from a nightclub or whatever. And then lastly, and from a medico-legal perspective, probably the most important aspect is documentation. I saw a scribe with the first team, with team 1. I didn't see a scribe with the second team, so I assume that what happened there will be documented later on by the team leader. So that is fine, as well as it is well documented. As already said, this will become very relevant later on in court proceedings. And you must remember, a court can actually subpoena any person or any document or anything as evidence in court. So just try always to keep that in the back of your mind, even though the stress of the situation and the patient may be overwhelming. Thank you.
Thank you very much, Dr. Rousseau, and to all our judges. So, Dr. van der Merwe?
Just one last thing. Hartbeespoort is not that bad, okay? I live and work around there. It's actually quite a nice place.
It was at Tant Marley's plek. We can say, I don't think Tant Marley exists anymore. So, yeah, that's why I said it was at Tant Marley's plek. Team, are we ready for the undergrads? Yeah. So I'm going to hand over to Prof. Sherlock whilst we wait. She has a question and maybe some interesting things about pharmacology.
Oh, okay. Now, yes, thank you and well done to the teams. Just wanted to ask, what do you think would be the effect of adrenaline on the heart, and what can you do to mitigate that? And if you were to give naloxone, what would be your considerations to monitor the patient? And would you give antibiotics, and why did you choose rocuronium versus pancuronium or any of the other agents? Thanks. Any team, any team. We can start with the rocket team and then anyone.
Hello. Oh. I think the adrenaline is definitely not going to be ideal. In my mind, we were heading towards an intubation, and I really didn't want to kill him with some of the drugs we were going to use for the intubation. So that's kind of where I was going. Luckily, he arrested before we had to make that decision.
Luckily for us.
Luckily for us.
Not for him. Yes.
What is the other question?
So why did
So yes, it doesn't pop into my mind because it's not on our scope. It's not in the pre-hospital space at all. But if it was like a transfer and they hadn't started, we would definitely start the drug, and we would leave it to the ED team, hopefully, to carry on with the antibiotics. And then rock, we didn't use rock at all. We were just going to do a ketamine only intubation with the rock that he already had on board.
Okay. And then naloxone?
So the naloxone, I think the risk is that he then becomes quite wildly aggressive. And if we reverse him and he's not obtunded because of a brain injury or something, we're going to fight with him in the back. So definitely in the helicopter, he's never getting naloxone, ever. Okay. And he's got rock on board, so that means it's keeping him nice and chilled. I think maybe if we were trying to get him to start breathing spontaneously once we were under control with everything else, it might be worth small little doses to just kind of see where we get to. But I don't think in our space we would have used the naloxone at all.
Okay. And the other team? Do you agree with them? Where's the other team? Yes. Yeah.
So in a patient who's profoundly hypovolemic like this case, there isn't really a role for adrenaline in the initial resuscitation. So let's close the taps, refill, and give the patient actual blood. And then if we have addressed the bleeding and we are doing an adequate volume resuscitation, after that is when we considered adding starting a low-dose adrenaline infusion just to try and optimize that physiological response. In terms of the antibiotics, we didn't get to the antibiotics. I was waiting to start with to basically finish stabilizing the patient after the primary survey. At that point, I'll consider my activated tetanus toxoid as well as antibiotics. In this case, with a gunshot crossing the midline, even though the PR was negative, there's a high risk for a rectal injury with an open pelvic fracture and gross contamination. I would probably consider a triple antibiotic approach in this patient. And then there's also the risk of, and we heard coarse crepes, so we were also suspecting an aspiration pneumonitis with possible ARDS picture as well. Which we'll also address with the use of antibiotics. And then just in terms of the naloxone, in a patient who's a chronic opioid user, acutely intoxicated, we just be worried about acute withdrawal, like they mentioned, and possibly precipitating seizures. So in this case, when we've already established a definitive airway and we don't have hypoxemia related to the actual opioid overdose, I would also not go for naloxone in this setting.
Okay, thank you. Just a few points. Yes, I agree with you, and these are some of the controversies that we have in pharmacology and emergency medicine. But the use of the vasopressors is primarily to have improved coronary and cerebral perfusion. That's what you want to achieve. And there's been many studies, head-on-head studies with adrenaline versus noradrenaline, or adrenaline versus phenylephrine, or adrenaline versus vasopressin. But what makes adrenaline good and bad is you have all of the alpha and beta effects. And the beta effect is what really increases your myocard's oxygenation. But what people often forget is adrenaline also has an effect on alpha-2, which works pre- and post-synaptically, and then would actually mitigate that effect. And I think that's why year on year it gives you that, it always has in all of the clinical trials, and there hasn't been many, but when these head-to-heads, it's that alpha-2 effect that you have from adrenaline. I agree with the antibiotics as well, and really sometimes the choice of antibiotics depends on where the gunshot wound is. For example, abdominal, then you'll think of a Bacteroides fragilis. And then yes, the naloxone is a tricky one, especially if you've got a chronic opioid patient, then you also have to inject it very slowly, otherwise you're going to have a lot of havoc, especially in your limited heli. And then just the other thing is many of these studies of noradrenaline, adrenaline, etc. in these patients with the myocard infarctions, trauma, many of them are done in animal studies. And when you look at the animal studies, those patients don't have very fragile arteries or veins that's full of atherosclerotic plaques. So you don't always see a reproducible effect. And the last point, the rocuronium, yes, I agree with you. And the other thing is just rocuronium is often used because it's nice and reversible and it acts immediately, but then it also has a very big allergic component, which we don't always anticipate in patients. Thanks.
Thank you very much. So I would like to welcome the Deputy Vice-Chancellor of Academic, Professor Loretta Ferris. She's just joined us from the Hatfield campus. Prof. Ferris' portfolio includes responsibility for all 9 faculties and the Gibbs Institute at the University of Pretoria. And it's a privilege to have you here this afternoon, ma'am, and thank you so much for coming to visit us, and you've actually arrived at a perfect time. We have our 3 undergraduate student teams that are competing now for 1st, 2nd, and 3rd place. We just completed our expert teams, so whilst we're busy with their marks in the background, please enjoy the entertainment provided by these students. Thank you, Wanda.
Everyone, please welcome back the Resus Angels. I'm not going to let them reintroduce themselves. We're just going to carry on and give them their patients. Guys, you have a 30-year-old male patient. He was found by his girlfriend this morning, seeming confused and warm. She called EMS. The patient was brought into emergency room with complaints of palpitations and dizziness. He now seems agitated and anxious. According to his girlfriend, he is a 10-pack-year smoker and uses cocaine sometimes. And he also smokes 4 joints of cannabis a day. Okay. She swears that he has been trying to quit the coke, but they attended a party last night and she's not sure what he drank or used. The girlfriend says he's been complaining of chest discomfort and feeling warm since this morning. He's right there on the bed. Please help him. Thank you.
Okay, guys, can we please make sure we get our PPE on? We're not sure what the patient was using, so just make sure you look out for needles, anything that is hazardous. Okay. Good morning, sir. Can you hear me? I don't know if he's responsive. Sir, can you hear me? Okay, I know you're very uncomfortable. I just want you to know that this whole team is going to help you, so can you just work with us a little bit? Okay, guys. Can we get some monitors on him, please? I need his pulse, I need his blood pressure, O2 sats. Okay, he is feeling warm to touch as reported by the paramedics, so can we just expose him? Please make sure we have a shield around the patient. We do want to maintain his dignity. Okay. Okay, guys, so just be careful. I see track marks on the right-hand side over here. Okay, so our pulse ox is on. Is he on nasal prongs? Can you put a face mask on as well, please, for me? Okay. Okay, sir, can you tell me, did you use any cocaine last night? No. Okay. So our patient has told us that he hasn't used anything. Have you used any other drugs?
He's not sure.
He's not sure. Okay. Guys, so I know our patient's reported that he hasn't used any drugs, but he was at a party last night, so we're not sure if we're dealing with alcohol or a stimulant here. Okay, our oxygen is connected. Can you get me bloods and 2 large wall IV lines, please? And blood gas as well, thank you. Okay, guys, can you tell me what his breathing is like? Is he breathing? Okay, let me have a listen quickly.
And blood's taken as well.
Okay, guys, so his breathing is all right. Okay, so we've got an airway, he's breathing, his pulses are normal. What his blood pressure is extremely high. So I'm going to, at this point, ask one of my experts to help me determine what potential drug of abuse we may be dealing with or substance and how to control his. Okay, so his rhythm has changed. Does he have a pulse? Yes, please check the glucose for me. Does he still have a pulse? No pulse. Flatten the bed for me. Start CPR. Can you organize a BVM and a definitive airway? Okay, start compressions. Okay, guys, and then can you get the defib ready, please? He's still responsive. Okay, don't start CPR. Do we have a pulse? Okay, it's a faint pulse, so it's a pulsatile VTAC. So can we get some drugs ready to cardiovert him, please? Okay, his oxygen, can we get, what is his GCS?
Do you need an oxygen bag?
Yes, please.
Can I get a BVM?
Okay. Okay, his blood pressure is dropping as well. Okay, do we have drugs ready for... Can I ask one of our experts to help me with a cardioversion in this patient? I don't want to give him the wrong drugs. Our experts are very quiet. Yes, please, Caleb.
Okay, you can cardiovert with 100 joules, it probably won't work. Maybe get some soda big ready.
Okay, can we draw up some soda bic, please? 1 ml per kilogram. He looks like he weighs about 70, so can we draw up 70 mils? Okay, so while we're doing that, can we get ready to cardiovert him? Does he still have a pulse? He still has a pulse. Okay, can we get ready to cardiovert him? He has a pulse and a VTAC. What is his GCS? Can we start? Can you have a look at his pupils for me? Okay, are they responsive? Okay, guys, please check for a pulse. We're in a VFib now. Are we? No, we're in a VTAC still. Torsade, I think. Can I ask an expert to help me with analyzing my rhythm, please?
Is it shockable or not?
This is a shockable rhythm.
Do it.
Okay, guys, can we please get ready to defib our patient? Let me help you. Okay, can you get the pads? This isn't working. Yes? Okay, guys, don't worry about that. Get these off me. Okay, check for a rhythm for me, please. Got a VFib. Okay, guys, can we charge, please? Do we have a pulse? Okay, clear the patient, clear the oxygen. Okay, perfect. Can you check if we have a pulse? If we have no pulse, can we start CPR, please? Okay, we have a pulse, or we have an organized rhythm. Do we have a pulse?
No pulse.
No pulse. Okay, so it's pulseless electrical activity. Can we start CPR?
That's mean chest compressions.
5, 6, 7, 8, 9, 10. Can I have a definitive airway, please? Okay, can we check his pulse again, please? Can we check his pulse first, guys? No pulse, continue CPR for me. Okay, we've got response. Okay, can we get repeat vitals, repeat blood gas and bloods?
Patient has a pulse.
Okay, so whilst we're waiting just to prepare the mannequin for the next round, anything else that you wanted to discuss in terms of pharmacology? We briefly touched on it, and as I said, I don't want to keep the program longer than intended. Okay, we're going to quickly talk about something controversial. Soda Bic.
So the group that was just here did a great case, and I think Soda Bic is an agent that was often used. And as we've just discussed here, it should be kept to toxicology because all of the other instances, it increases your intracellular carbon dioxide, which then actually has a very negative effect on the myocardial tissue. And then extracellularly, it shifts to too far right to the alkalotic component. And then it causes an increased attachment of oxygen to hemoglobin and interferes with oxygen release. So if you use it in other instances, it's actually more detrimental than when it is useful. Thanks.
All right.
We are the. Oh, sorry, let's give it like. There we go.
Hi everyone, we are the Heartbeat Heroes. Okay, should I quickly introduce everyone again, or? Okay, awesome. Hi everyone, my name is Marcel. I'm team leader. I am 5th year medical student.
Hi everyone, my name is Amara. I am 2nd year sports science.
I am Tombi, a 3rd year nursing sciences student.
I'm Yana, 2nd year medical student.
I'm Nicola, a 4th year medical student.
I'm Jason, a 1st year B Sports Science student.
Okay, welcome back, team. So your patient this afternoon is a 30-year-old male patient. He was found by his girlfriend this morning, seeming confused and warm. She called EMS. The patient was brought into the emergency room with complaints of palpitations and dizziness. He now seems agitated and anxious. According to the girlfriend, he has a 10-pack year smoking history. He uses cocaine sometimes, and he smokes 4 joints of cannabis a day. She swears that he has been trying to quit the coke, but they attended a party last night and she doesn't know exactly what he took or what he drank. The girlfriend says he's been complaining about chest discomfort also and feeling very warm since this morning. Please go ahead and help your patient.
Guys, just quickly, just brief before our patient comes in. So we have a 30-year-old male patient coming in. He feels anxious. He's not unconscious at this point in time. He possible history of thinking of cocaine use and possible drug induction. Okay. Right, put on a PPE, everyone. Let's get to the patient. Hello, sir. Hello, sir. Are you awake? Are you awake? Okay, the patient is awake. Sir, can you hear me? Can you hear me, sir? Okay, I'm checking for breath and pulse. And looking for breath. Cannot feel a pulse on the patient. All right, patient doesn't have a pulse. Please let's start CPR, team. The patient is breathing. Sorry, let me just check for pulse again, guys. I mean, let's not start this wrong. Okay, the patient does not have a pulse. Let's start CPR, please, team. There you go. Off the bed, start CPR, please, team. Thank you very much. Please get the BMV and start the airway. Thank you very much, Amara. Thank you, Jonna. Thank you for starting the time for us. Please start the tempo for us. Thank you very much. Is he moaning and groaning? Please just feel the pulse again. Just stop CPR and feel the pulse again, please.
I've started rescue breath.
Thank you very much. There we go. The slight pulse. Can you feel a radial pulse?
I can feel pulse, yeah.
Okay, feel radial. Okay, that's okay. Please stop CPR then. Please continue the rescue breath for us there. Tommy, can you please put up for us 2 large bore IV lines as well, please? Jason, will you please help connect the ECG monitors for us, please? Can you please also get a temperature probe up and end-tidal CO2 for the patient? Thank you very much.
2 IV lines inserted.
All right, thank you. Just can we hang them up there, please? Thank you very much. There we go. All right, just get those monitors up, guys. Thank you very much. We can just get some vitals on the patient. You can just, thank you, Jonna. He's doing well with the timing there. Okay, we have a sinus rhythm, guys. We're happy with that. Oh, SO2, okay. The patient is tachycardic. Can you please just quickly examine the pupil cells in me, please?
So the pupils are not reactive to light.
All right, thank you very much. Oh, they're dilated. All right, thank you very much. While you still set up there, Nicola, please to continue with that. And Tommy, can I please ask you to get some diazepam for us along, please? Just draw that up for us along. Thank you very much. We're suspecting the patient, yeah, we can see some needle track marks here on the arm as well, suspecting a cocaine overdose. Please just keep this person is still in the sinus rhythm, that's good. His BP is very high at this point in time. So can you please put for us 1 amp of diazepam with flush, please, and Tombi. Please get that in for us. Thank you very much.
1 amp of diazepam given with flush.
Thank you very much. You got the rescue breath under control there, just every 6 seconds. Well done. Thank you very much. All right, there we go, team. Let's see if it has an effect on the patient. His BP is still very high. His heart rate is high. Right, I'm going to please ask, we can ask some expert opinion just to get some advice on where to go from here, please. Ooh. Okay, our rhythm, guys. We are in a VTAC for the patient. Please feel as a pulse, Nicola, and then proceed to shock. No pulse. Please.
Heavy pulse, heavy radial pulse.
Is there a pulse?
Yeah, fast.
Okay, then we need to. Don't feel a pulse there. Okay, let's please complete the shock. I think this is a pulseless VTAC. We wanted to shock the patient. Please charge there for us. And clear. There we go. Please disconnect oxygen. Right, please analyze. There we go. Shock or rhythm. Please shock, Nicola. Right. There we go. Everyone take care of the patient, please. There we go. Thank you very much. Jason, please start CPR immediately for us. Thank you. Start CPR. Thank you very much.
Voltage.
All right. Voltage, Nicola, for the shock. Here we go. And so just continue those rescue breaths every 6 seconds. Thank you very much. Just a bit faster on the. There we go. Just a bit harder and a bit deeper. Good recoil there. Thank you, Jason. We appreciate that. Thank you very much. And so can you?
5, 6, 7.
Thank you very much. Can you please get another ample of diazepam ready for us, please? We also want some adrenaline ready. Can you please get 1 milligram of adrenaline with flush ready for us as well, so long? Please continue those CPR. Jason, thank you very much. How long before our 2-minute cycle is over, Jana?
Given
Thank you.
1 ampule of adrenaline per 130.
Okay, thank you very much. 130 still, okay, still a long way off.
HL inserted 2 breaths.
Thank you very much. There we go. Continue CPR, Jason. Thank you very much. Just continue. We have a minute left before our next pulse check, so please continue with CPR.
Did you give 1 amp benzo?
Yes, we gave only 1 amp of benzo so far. Thank you very much. There we go. Let's continue CPR. Good team. Well done. That's good. Sharp.
What did you give syphilis?
We gave 1 microgram of adrenaline for the patient. There we go. Will you guys expose the patient first and check if there's any other obvious signs of bleeding or hemorrhage? We'll start with the H's and T's. Okay, there we go. Nothing there. Let's just cover the patient here as well. There's no priapism that you can see on the patient.
Jana, what's the time?
48 seconds.
Will you please get the ultrasound ready for us to do a quick e-fast of the chest and heart when the next pulse check in Tombi, please?
Ultrasound ready.
Thank you very much.
Oops, it's used at another patient.
Okay, use another patient. We can't do an ultrasound. Thank you very much. There we go.
36 seconds.
36 seconds left. Continue your
compressions.
CPR. It looks good.
Nice breaths.
Well done. There we go. Temperature is still high. There we go. Our fluids are still running. There we go, guys. Our peripheral lines are up.
Nice steps.
Can you, Tommy, will you quickly just listen with a stethoscope, or like maybe listen, use a stethoscope and just listen for breath sounds, please. Also with the let me give it to you guys.
9, 8, 6, 7,
There we go.
5, 4, 3, 2.
All right, stop, guys. Please swap. Analyze for a pulse there. Can you please listen to the chest sounds quickly, please, Ntombi? Can you feel a pulse?
No.
Okay, the patient has a soccer ball rhythm. Please charge and continue CPR. Thank you very much. Here we go, Mara. Nice CPR. Thank you very much. Good chest recoil. There we go. Please charge. There we go. You ready? All right.
Charging.
There we go. Charging fast, please.
Clear, unclear.
Take it. Take the oxygen is clear. Everyone's clear. All right. There we go. Shock delivered. Please continue CPR. The Jules was Nicola.
200.
Thank you very much. Continue CPR, team. There we go. It looks like we're getting better momentum. Just continue CPR, please, for the next 2-minute cycle. Will you please get us, see the needle track marks? Let's start with the H's and T's and Tommy. Let's quickly go through from head to toe. Will you check if there's any head trauma for us quickly? See any open wounds, any bleeding there? Please have a look at the patient's pupils again for us.
The pupils are stated, they're dilated.
All right, please check if there's any signs of hypoxia on the patient as for us as well.
Nice compression.
There's no central cyanosis.
Okay, thank you. I see our stats monitor is also up. We're happy with that. Thank you very much. Will you please just take some bloods for arterial blood gas, please?
Taking blood for the arterial blood gas and taking blood for laboratory testing.
All right, is the blood gas machine working?
Aish, no.
Okay, that's
But I'm going to
fine.
stop you right there. Thank you,
All right.
guys. Well
Thank you.
done.
Guys, whilst we're waiting for the next team, if there's any burning questions, we can answer them now. We are not going to have a formal debriefing after the the three teams again. We'll just have sort of an interaction, and then I would love to hear from the students in the audience what they thought of their peers' performance, seeing that we heard from the experts and the judges this morning. And that is just to allow Vian to calculate all the marks, seeing that the prize giving and the word of thanks will be conducted just after that. So that said, any questions from the audience? Any remarks? This is a typical nurse stance. I don't know if you've seen nurses. We all have back problems, so we always have a leg on a bed or on a chair. Okay. So I think the next team is just preparing. We're going to start shortly.
Sorry, guys, we're just waiting for one student. Sorry. Please welcome the Bloody Angels. This team doesn't want to introduce themselves again. They say you all know them already, so I'm going to go right ahead and read. I'm going to read out your patient. Okay. You have a 30-year-old male patient. He was found by his girlfriend this morning, seeming confused and warm. She called EMS. The patient was brought into the emergency room with complaints of palpitations and dizziness. He now seems agitated and anxious. According to his girlfriend, he has a 10-pack-year smoking history and uses cocaine sometimes. He also smokes 4 joints of cannabis per day. She swears that he has been trying to quit the coke, but they attended a party last night and she doesn't know what he drank or what he used. The girlfriend says he's been complaining of chest discomfort and feeling warm since this morning. Please go ahead and help your patient.
Okay. I'm putting on my gloves and approaching the patient and calling my EMS team. Hello, sir. Hello. Okay, the patient is unresponsive. Oh, he's gasping. Hello? Can we get his airway secured, please?
He's vomiting.
He's vomiting?
I know, he's making noise.
Is he vomiting?
No.
Moaning, just moaning.
Moaning, okay. All right, Byron, can we please get a rebreather mask on him as well?
Can I put on the monitor, team leader?
Yes, please. Thank you.
Sorry. Thank you.
Can I listen, lungs?
Yes. I can't feel his pulse. So, Manga, will you also please just check his pulse?
Okay. There is a pulse.
There is a pulse, okay. Anya, can we please get...
The daily ECG is also connected to the blood pressure. The monitor is also connected to leader.
Okay. Thank you. Can we please get 2 IV lines up of fluid? And can we also please do a tox screen and a full blood count, UNE as well as an ABG?
What do I see on people's?
Rebreather connected.
Both is dilated.
Dilated, okay. Drugs, can we please start an infusion of midazolam? Okay, his blood pressure is very high. Can we also please start labetalol?
I'm going to start using a bag of mask.
Okay.
Doing bloods.
Drugs, have we given the midazolam?
Yes, I have.
Leader.
Okay, can we also do labetalol, please? Labetalol, yes.
Thank you.
Thank you.
I'm administering Lepetalol administered.
Thank you. Is airway fine? Byron?
I think he's vomiting. Let's log roll.
Okay, he's in VTAC. Is there a pulse? Can we get the bed down, please?
Checking the pulse.
Is there a pulse? Okay, can we please get the paddles on and get ready to cardiovert?
Exposing patient to the fire.
Thank you.
Okay, I'm switching to an agile. Just now the agile.
No injuries noted on extremities.
Sinking.
Yes.
Agile in. Sinking, confirming.
Okay, BP is a bit low. Can we please, we've already hung fluids.
Fluids in.
Can we listen to chest sounds, please? We are struggling with airway, please. Can you address airway?
Okay.
Well, airways, but
Desaturate.
Can we suction, please?
Yes, can we please hang another bag of fluids, Anya?
Now, please.
Just decrease air entry. Low.
Okay, how are we on the manual defib, please?
Okay, I'm ready.
Okay, can we cardiovert the patient? Get ready.
Okay. Gel, please. Gel applied.
Is there a pulse?
150 joules. Charging.
No pulse. We need to shock the patient. Is he in VFib?
Shock the patient. Charging. Yeah.
Clear oxygen.
Charge.
Shock.
Shock.
Okay, the shock would have been delivered. Please continue. Please start chest compressions.
Shocking. Hold. Okay.
Everybody clear?
Everybody clear. Oxygen is clear.
It's not shocking because check the rhythm. Something is not making something.
We're exiting sync. Thank you. It's not in sync anymore.
Okay, charging again. It's 200 joules. Charging. Clear the patient. Oxygen is clear. Charge. Shock administered.
Continue chest compressions. Time.
3 minutes.
Can we get oxygen sats, please?
That's on, but he's not going to have a stats because he's in cardiac arrest.
Thank you.
Can we check the gas results, please?
Yes, can we please have the gas results?
The machine is offline.
Okay, he's also got a bit of a temperature. How are we with time?
Seconds in compressions.
Team leader, have we given anything for the possible drug overdose?
We gave midazolam earlier.
We need naloxone, team leader. It's a stimulant.
Pupils were dilated.
Okay.
We're still going with compressions. Can we please have harder compressions?
What's the time?
116.
Okay, we've got sinus. Can we feel for a pulse?
Is there a pulse?
Can we
30
have
seconds.
confirmation of a pulse? Oh. Okay, there is a pulse. Sinus is maintained. Can we
Thank
have
you,
a blood
guys. You
pressure
can,
reading, please?
you can stop. Thank you very much. You should feel for the pulse. I'm not telling you. Okay.
So everyone can take a seat. We are just getting all the feedback from the judges so that we can get the announcements ready of the winners. In the meantime, I'll start a conversation. Why did the machine not shock the patient when it was synced and the patient was in a ventricular fibrillation? Can someone hand a mic there to one of the team members there next to Vian? Is there a mic close?
So it won't shock if there's no QRS complex for it to sync to.
Do you agree? Caleb?
So on some machines, the newer machines, if you have a look at any of the machines coming out of Europe, they don't even have a sync button anymore. They synchronize every single shock. So if your software is updated to the latest versions, you can cardiovert every shock.
Wow.
Yeah, it just disregards it if it's irregular and gives the shock whenever. Yeah, so we still have to use the proper thought process. Yeah, but the software is not as new as you could get in other places.
That's very interesting. I also learned something today. Okay. Yes, Dr. van der Merwe. Zanique, is our mic here with Dr. van der Merwe on? Use mine, Donnie. I think everyone's glucose is running low.
Hello?
Perfect, thank you.
I think it's very important when you work in the emergency department to understand, to know your defibrillator. Because depending on the manufacturer, I think the logic is different. Some of them, after you've delivered the shock, some of them would automatically disable the sync and others would keep it enabled. So the big thing is when you try to cardiovert a VTAC and then it goes into a VF, you need to make sure the sync button is off. So you need to know your machine. And the best is every time before delivering a shock is if it's a pulseless rhythm with a pulse, make sure your sync button is still on and shows that it's syncing. And when it goes into a VF or pulseless rhythm, make sure the sync button is off. Otherwise, you're going to stand there like a fool and waiting for it to shock, and it's not going to shock.
Interesting question, Dr. Rousseau. Maybe if you can help us. If a defibrillator in an emergency department is not checked every morning, and a patient should suffer a dire consequence as a result of that, who's to blame? The unit manager, the shift leader, the nurse responsible for checking the defib, or the doctor in charge of that emergency department? Who will go to court?
By default, it's always the doctor's fault. Everything that goes wrong is the doctor's fault. That's my experience. But no, it's basically the same as with the so-called Section 56 cases of 56 deaths. It depends on the protocols of the institution, who is responsible primarily for checking that equipment. Same with anesthetic-related equipment, so the same will apply here. So it depends on the institution, what the protocols is, or who is the person responsible for that. But ultimately, I suppose everybody along the line should also familiarize themselves with whether this apparatus is functional or not. So in the end, probably every case will be judged on its own merit based upon witnesses and expert witnesses in the court.
Something very important to remember. I recently joined the fraternity of medical legal cases, and I must tell you, documentation is what gets you into trouble. It's not decisions, it's documentation that ultimately boils down. Whilst we're still busy with the marks, Caleb, I was wondering if maybe you can tell us something about the dual defib things that you discussed at the past conference. Can we just maybe hand a mic there to Caleb? You wanted a head injury, so we can land the heli. So
That was kind of
let's
the
do
plan,
it.
if anyone wants to volunteer.
Okay.
Okay, so dual sequence defibrillation is not really new. It's been around for quite a long time, but we really haven't had much data to support it. In the last little while, there's been a few more really small studies that maybe show it might work in the early stages of cardiac arrest, especially if it's a shock refractory VF. So if you've shocked up to 3 times and administered a single dose of amiodarone, so a 300 milligram dose of amiodarone, it's probably worth thinking about either changing your pad placement, so just moving them from an anterior placement to maybe an anterior-posterior placement, or if you happen to have 2 defibs that are available, putting both sets of pads onto the patient, one anterior-posterior, one anterior-anterior, and then charging them up to their maximum dose and shocking them at within 1 second of each other. And then one of 2 things will happen. The patient will either go into an asystole, which means you can declare without feeling sad, or on the plus side, if you get it done early enough, you might get a return of circulation simply by terminating that VF.
It's very interesting physiology behind that, because I can just imagine, does the studies mention the damage to the myocytes from this?
So it's nicer to have a cooked heart than a dead heart.
I hear you. Yeah, I suppose the ATP gets depleted the longer the patient's in VFib, so either way.
I don't know how you would measure the kind of damage, because you'd have to have survivors on both sides.
Or maybe Dr. Rousseau can measure it afterwards. Okay.
Yeah, there doesn't seem to be any increased risk of damage. And I know in peds you can go all the way up to 10 joules per kilogram before you start getting like proper damage to the myocardium. So in adult, you're probably safe within your 360 joule range on any machine.
Okay. Anything from the students there in the back? You want to give feedback on the team's performance? You want to say something about the expert rounds? You didn't have the opportunity earlier on, so now's the time. Once I put this mic down, we're done talking. Yes, Vanda wants to say something.
Thanks, guys. I would just like to tell or explain to all the judges or everyone here that we don't really teach our pre-grads. We don't focus on synchronized cardioversion. Okay, so well done for those trying and seeing that that was a VTAC with a pulse. So we focus very much on shockable rhythms, and with the new curriculum and simulations, we are going to change that. But yeah, so this was a little bit of a twist of a scenario for them, and yeah, they don't really know the full concept of cardioversion by itself. Okay, but well done.
Undergrad students only get training in basic life support. So they only get exposed to some sort of advanced cardiac life support measure in their 5th year, in the trauma block with Prof. Brandt. But before that, the only exposure they have is, where was that first year? Histology and 2 rescuer CPR. Do you like histology? Me neither. Anyone want to give some feedback on their teams? Let's hear.
Oh, I also want to give a bit of feedback. I think I liked how our team was the second round. We were very calm, and yeah, it was so nice and calm. And also on the experts round, I liked the first people, like they were very calm, and I don't know if he's the team leader, but he did like a very thorough check. He was able to notice the wound and just everything. So yeah, it was really nice. And the orange overalls people, they were very funny. Yeah. Yeah, they were very funny, and like, yeah, they looked really cool, and they did a great job too. Thank you.
You must ask Dr. Yuan what he does when they fly over a prison. They fly faster. You wanted to say something, sir?
Yeah, it was just amazing interacting with students from different degrees, because we don't get that often studying sports science on the Hillcrest campus. It was just amazing having something where you were like different years, different degrees, and interacting and so on. So yeah.
Okay, very great. Thanks. Okay. we're going to take about another 5 minutes just to check the results. So we're almost there. And I think Prof Vanessa just accompanied Prof outside because she has another meeting I realized now that we can't say main campus anymore, it's Hatfield campus. The Dean said this is main campus. So we're just waiting for Prof Vanessa. If she's delayed, then I will go ahead to do the word of thanks so long and hand out the presents for which we do have the results available. And everything is verified. And there, I spoke to Dr. Tammy Bailey-Stanton earlier, and just in terms of ethics, do you think that people should be allowed to see each other's mark sheets, or is that something that's confidential and needs to be decided by the groups individually?
Hi, so this sounds very much like exam stuff as well. Students don't ever get to see other people's exam test marks. Marks are happily available to teams, but you can't see somebody else's exam paper. That's not fair, it's not ethical. The whole thing that comes around when there is testing is we have to have stringent rules in place. And you have examiners who have nothing to do with scenario design. Then you have participants who have nothing to do with scenario design. And then you have the overall organizing committee who does have to do with scenario design, but they're not involved in allocating marks. So for this reason, it's not really fair to see other people's marks. If the processes are stringent and you need to trust in those processes that they are, especially when a lot of attention has been paid to making the process fair, that's why outsiders are invited. You have external, potentially internal examiners depending on where it is, but that's how things are kept fair. And then overall, once you have a whole bunch of test results, you'll have somebody who adjudicates the overall and has a look at the final results to see if they're fair. And that's the process that has happened.
So it's my pleasure to ask Prof Vanessa Steenkamp, the Deputy Dean Teaching and Learning of the Faculty of Health Sciences, to do the word of thanks so long, and then we'll proceed on with the prize giving. Prof Vanessa, I'm handing over to you.
Sure, what a fantastic day. It was such a pity I couldn't actually attend the whole scenario. I was getting so excited. I don't even want to know how the rest of you felt, even the participants. It's really such a learning opportunity. And that was not possible without so many people that have put in so many hours. At least I was there from the start with the planning to support, but it's such a great idea, and it's something that we really want to take forward, going internationally, and hopefully this will happen next year. So let me start with the long list of people that I need to acknowledge for their generous sponsorship: to Rocket Hems, Air Rescue Africa, Mr. First Aid, Survival Technologies, Zebra Medical, Critical Care and Emergency Services, EM Pret, Netcare, Africure, SASS, and then actually to the Faculty of Health Sciences, to all our staff that really dug into this, and I think thought together with all our special guests, or some of our special guests, on the scenarios. I'd also like to thank the following special guests: the speakers, naturally, our judges, the experts, the exhibitors, and also the media and the people that were doing all the filming, ready to take it out to those that were watching and showing what goes on, for the interaction that we had here, the discussion. I mean, that is the important part of learning, of what did I do wrong, or not maybe did wrong, because I must be surprised, they all saved the patient. It was just a bit different, and why, what would have been a better scenario. But the judges also for sitting here the whole day and, you know, and also giving their input. Thank you so much for that. I would also like to say thank you to the heads of department that were made it possible that they could attend, or were able to attend, sorry, the chairpersons of our student societies and other staff of the faculty. Our Vice Principal Academic, Professor Ferris, although she could only just join us for a short while, I can tell you that's why it took us so long to come back. She is so into this. She thinks it is absolutely fantastic, and she said congratulations to the faculty and to everybody for hosting this. Ronelle, thanks for your idea. This is really an excellent teaching and learning opportunity. Our former dean in the Faculty of Health Sciences, Professor Duplessis, that wasn't be able to join us in person, but is really a very avid supporter of our Faculty of Health Sciences, as we hope all our alumni would be. Our current dean, Professor De Jager, was always there to support. Our faculty manager, Ms. Karen de Prier, who helped with a lot of the arrangements as well, and also getting the helicopter in here at the back. The school chairs and societies, once again, that helped with the plans, also trying to get the teams together, and all our students. And, you know, just having this transdisciplinary team is just such a fantastic idea. You know, I was listening here, you know, students that are at first year level, that are prepared to participate. I mean, already you are just, oh, incredible, absolutely incredible. And I think we're going to have, like we did last year, with a lot of the students just standing back and saying, oh, you know what, next year. And then they actually say afterwards, you know what, I should have participated. It's just an unbelievable learning experience, and an experience just overall to do. Our Chief Medical Officer from Rocket, Dr. Johan Horn, our Clinical Governance Manager from Rocket, Caleb Laschenicht, and the Emergency Care Practitioner from Rocket, Sean Skuman. This morning we're also saying, listen, yeah, everybody is now family. They're part of our family, part of our university, and our faculty. We see them often whenever we have these events, if it's CPR, emergency, or whatever, they're there. This is the second time. These are going to become part and parcel of the faculty. So thank you very much for joining us in this. The Air Rescue Africa Base Manager, Karine Basson, Air Rescue Africa Nurse Flight Nurse, Kate Holiday, the Clinical Head, Mr. First Aid, Sean Groom, thank you very much. The Hospital Manager from Netcare, David Stanton, and our industry partners, Survival Technologies, Mr. Rod Campbell, the Critical Care and Emergency Services, Mr. Higup Minar, and Zebra Medical, Ms. Callan Ludik. Our National Nurse Manager, Netcare Diagnostics, Faces Base, and Africure SASS. Okay, this is quite a difficult name. Makshuda Kaji and Mike Perry. Crikey Moses, I'm telling you, it shows you what a team this takes. But wasn't this a clan with an innovative clan today? I must say, a hand of applause to everybody that participated and just for everything you did.
So Provenessa's office generously sponsored scrubs for the best dressed team, and I do hope they are here. She's also included a note for you there so that you can have your scrubs personally embroidered. I would like to know, are the Resus Rangers here? Please come forward. Congratulations, guys. Please come and show us your scrubs. We would love to see what colors you choose.
I mean, I thought you were actually going to bring the snakes along.
Whilst we take a photo, will Dr. Wayne Grobler from, I believe I said MPRET the whole day. It sounds so nice, but EMPRET, please join us in front to congratulate the upcoming emergency star. And I do hope I get this right when I say it. And if this team member is not here with someone from her team, please just come and receive an MPRET-sponsored ECG course to the value of 1,800 Rand. This is awarded to Nomkobo Vika. Nomkobo Vika. Can you accept on her behalf? Thank you so much.
She was our team leader for Team 4, aka Pulse Force. She had to leave, I'm guessing, some errands, but no, she really helped a lot. She did.
Thank you very much. Congratulations. Just a photo there with Dr. Grobler. Okay. So I'm a list person. Let me just make sure I do this correct. All right. Then seeing that the undergrads was the most important guests today, I'm going to proceed with the winner for the expert round. And I would like the team captains to come forward, Dr. Wayne Grobler and Caleb Lachtnick, because believe it or not, you can have this adjudicated by PricewaterhouseCoopers. You tied. Congratulations. Can I please ask the Dean to join the Deputy Dean just for a photo with our two expert team captains? Then I want to ask Mr. Sean Groom from Mr. First Aid to come to the front to award the prizes to the third place team of SimUPWars 2023. Can the team Risa's Angels please come to the front? Congratulations. You are third. Congratulations. There's some very fancy first aid equipment in there that you can carry in your car and that you can use at a scene. Thank you so much, Sean. Sean, just a photo. And then seeing that Stellenbosch challenged us, there's also very fancy travel toothbrushes in there when we travel to them next year to go and beat them. And Mr. David Stanton from Netcare Millpark. I don't want to make a presumption, but is Millpark the only level 1 trauma hospital in Gauteng? Union, Alberton? Okay, all right. So very big hospital, very big price. Can the Bloody Angels please come to the front? You get the opportunity to work an observer shift with Mr. Stanton in a level 1 trauma, accident and emergency department. Okay, so the students must please just arrange their shift in convenience with the hospital and according to the regulations required for you to work the observer shift. I want to add to that Zander Loubser that drove the dean here this morning in that very fancy response car has also generously offered any student who wants to come and work observer shifts with him on the response car. The response car has arterial blood gas machines on board, it has point of care, it can administer thrombolytics, it's in contact with the cardiologist at Zuid-Afrikaans, so you can just arrange a shift. The base is very close to campus and then you can go and work with Zander on his car. That said, no surprise, Heartbeat Heroes, you are SimUPWars 2023 winners. I would like to invite Dr. Johan Horen from Rocket to the front. Then on behalf of Mr. Hugo Minnaar, who is the Director of Critical Care and Emergency Services, he's currently working in Zambia, so he can't be here, but his prize is here. So that said, you guys win an observer flight with the Rocket EMS operational machine. So thank you very much, Johan, for giving the students this opportunity. It's really amazing, and I do hope you guys enjoy it and that you get to fly that day and that it's so busy, you can only come home after 36 hours. So enjoy it. You can stand here, and then I'm going to ask you, this is from Mr. Hugo Minnaar. So it's a BLS course with his company. You can attend it any time from now until the end of next year, December. And it's valued to, I can't remember what a BLS course is these days. 1,500 rand. Daar moet 6 wees. Okay, thank you very much, Jan. And then obviously, Jan, as outgoing champion, I think you should probably give this to them. So Vian's team won last year. And congratulations to him. And congratulations to you. It looks like Wimbledon. Then I just want to say a final thanks to, once again, he feels like he's that, you know, that guy in Matrix that get all the awards. Dr. Grobler, can you please come to the front? On behalf of the Skills Lab and the Faculty of Health Sciences, thank you so much for, in your position as a registrar, taking your, when you have your minimally time off, that you invested it in our students and that you were such a great mentor to them. I spoke to them a lot afterwards, and I mean, they had so much appreciation for you. And it was a pleasure to have you in the Skills Lab. Thank you very much. Good luck with the exams. Looking forward to those results. And then I want to thank the mind, body, and soul of SimMan, Mr. Rod Campbell. I think he's so tired. Rod, thank you so much for putting up with a bunch of ICU nurses, deciding on the bed, should it be this way, should it be that way, should the mannequin do this, should the mannequin do that. As always, we really appreciate you, and yeah, there's no words. Thank you so much for investing in our students. Okay, and I think that brings us to the end. Finally, I'm going to ask my team from the Skills Lab. Guys, this is a lot of work. I don't think you have any idea how much hours goes into this. And without these ladies, none of this would be possible. And like I said, I'm going to say it once more, ek het 'n idee. They hate me whenever I come with something like that. So I'm going to ask them to please hand out these gifts to the judges and experts. Thank you so much for joining us today. I know a lot of you come from private practice and you offered your day. Also to those working in the government sector, there's a lot of hours that was put into this day. And thank you for doing it for us for free. It's really appreciated, and we are proud to be associated with you. So we'll hand out the gifts to the judges and the experts as they pass down here. Then they can also take a photo. Thank you so much, everyone. Have a blessed Wednesday.
Ladies and gentlemen, before you all leave, Runel, you may have Monday off. Can we give Runel a big hand of applause?